if it is a peripherally located lesion, the dose is 15 gray in 3 fractions, into 3 fractions, and for centrally located tumors it is 12 gray and 4 fractions. Now coming on to liver. The surgery is still the gold standard for long-term survival, but SBRT provides excellent local control in patients who are unfit for surgery or those patients who have tumors in challenging anatomical locations. And then the conclusion of the trials was 2-year local control was 70 to 95% with a median survival of 18 to 48 months. And the dose for SBRT liver, when the lesion size is less than 3 centimeters, it is around 48 to 60 gray. When the lesion size is between 3 to 6 centimeters, we increase it to 60 to 75 gray. Coming on to brain mets. So there are many options. We have nearly 6 options. But the level 1 evidence is given through RTOG 9508 trial, wherein the overall survival had an improvement of nearly 2 months when whole brain RT was followed with SRS. It had level 1 evidence. The other level 2 evidence was very evident when surgery was with whole brain RT versus SRS with whole brain RT. So with this again they gave equal results when the tumor size was less than 3 centimeter. And again the tumor dose according to RTOG 9005 for lesions which were less than 2 centimeters was 20 to 24 gray in single fraction, 22 to 3 centimeters lesion was 18 gray in single fraction, and 3 to 4 centimeter lesion was 15 gray in single fraction. We have other dose variations as well. So the last, the fourth option is oligometallic disease of the spine. Here again we have various options like definitive and post-operative re-radiation plans, but for spine, the local control at 1 to 2 years is nearly 70%. When you add radiation, it increases to around 85%. And the overall survival is similar to surgery in the SBRT arm. So these are the various trials for different trials specifically for de novo patients, de novo spine mets, re-radiation spine mets, and post-operative spine mets. So then the dose fractionation for definitive RT, we need to keep the bed value more than 50 days. That is what we need to remember. The last mets which I have decided to discuss is about the adrenal mets. Here again, the SBRT is the effective alternative for patients who are unfit or unwilling for surgery, with a median dose of 50 gray and a median number of fractions of 10. So there are many studies, trials going on when comparing only SBRT or SBRT with CDK4/6 inhibitors, and we also have many new drugs coming up for the systemic treatment as per the ASCO updates in June 2025, which we are not going to go into detail now. The last thing is challenges. What are the challenges you are facing in the management of OMBC? So we are not able to definitely determine the exact location of the patient's cancer along the spectrum, because the definitions are there but it is not standardized. The imaging techniques are there but it is not being standardized. And again the biomarkers we are able to diagnose but it is not yet standardized. And the other thing is we need to know whether the benefit of local ablative treatment on the metastatic site is overshadowed by the effectiveness of standard of care systemic therapies. So all these things are the challenges we are facing. And the future directions and take home message, we need to incorporate molecular based definition. We need to develop specific biomarkers using liquid biopsies. We need to standardize the advanced imaging techniques and identify subgroups who may benefit from aggressive intervention. And we need to improve our focal ablative therapies. Establishment of prospective observational studies which study the impact of systemic treatment on treatment of mets. And then finally we need to implement larger phase 3 trials. So what is the take home message? 15 to 40% of metastatic breast cancers are oligomets, and we are looking at curing this percentage, nearly 40%. We are, instead of giving them a deadline, we are trying to cure them. And the surgical aspect, primary tumor resection, is effective at improving the local, regional, progression-free survival as well as the overall survival, mostly in bone-only mets and hormone receptor positive, HER2 negative patients who are less than 55 years. We do have very encouraging endpoints of local control, overall survival, progression-free survival in SBRT for OMBC. So we have come to the conclusion that SBRT treatment management in OMBC is equivalent to surgical management in OMBC, organ preservation. We are awaiting phase 3 trials. So the big question mark is, do we need to pause our aggressive treatment strategies till we get the phase 3 results? Thank you. Any questions?
Thank you, Dr. Grace, for the wonderful presentation. One question I have for you, ma'am. One clinical situation which we face in our day-to-day clinical practice often is while doing PET-CT for a locally advanced breast cancer, FDG PET-CT often pick up some indeterminate lung nodules which the nuclear physician commented as suspicious for metastasis. Those are not amenable for local treatment. In such scenario, how you handle it?
The initial definition, sir, I have given it as it has to be amenable for local treatment.
Okay. So in this scenario, how you are all treating, whether it is locally advanced, taking it as locally advanced or as oligometastasis?
That it depends, madam. We need to individualize the patient's treatment.
So, what you can do is you can just treat the patient as like regular this one. Look for the nodule. How is it after the chemotherapy or whatever?
After NACT, if it is
response,
we can take it
just
as
the clinical
next.
judgment. You'll have to take it forward. Because if you're not able to do a biopsy, then you have nothing else. So coming to Dr. C, I just wanted to know what is your take on non-spinous bone nets?
It is beyond the scope of discussion for this particular case, but there are many trials, but there are no specific SPRT guidelines given for non-spinous osseous mets. That's why I have given it as bone mets, but I'm going to discuss only about spinal mets.
Because we do see some patients who are getting in the neck of the femur or femur, single solitary mets.
There are more trials only for spinous SPRT.
That's why mainly this topic was to identify where non-spinous bone mets what you are doing. So we have treated 3 or 4 patients. The patients are
we are treating, sir. As you said, we are treating, but it's not been validated.
Thank you.
Excuse me, I have only one comment to the MC. The MC introduced as Mara David's daughter. The opposite should be introduced. Mara David is the Dr. Grace brother. She has, on her own merit, a lot of achievements.
Thank you, thank you, sir. Thank you so much.
Thank you, ma'am, for a truly insightful session. May I invite the chairpersons to honor the speaker?
Sir, it would be a great honor if Professor Balu David joins us.
He's taking video.
Sir, please do the honor of felicitating the chairpersons. Thank you, sir. Thank you, ma'am. Proceeding on to the next session, we welcome Dr. S.P.S. Bala sir, MMIM sir, Bulana, Haryana, and Dr. Sasipriya ma'am, Harshamitra Hospital Chief, to chair this session. Topic is about total neoadjuvant therapy in rectal cancer.
I welcome Mahalakshmi Prasad from Mohan Medicity, Madurai, for this
topic, rectum TNT.
Discussion today is total neoadjuvant treatment in rectal cancers. So first of all, I would like to thank AROI President Dr. Balasubramanian sir, Secretary Dr. Balaji sir, and the organizing team, Professor Dr. Devanayagam sir and Dr. Rajkumar sir, for giving me this opportunity to talk on TNT rectum. So my association with Tirunelveli Medical College is a long history. I think if Professor Dr. Selvamani ma'am is here, she will definitely agree with me.
And I was asking him again and again, sir, the paper now fill panno seekram pannunga madam. And when ma'am came also, the status was poor, and ma'am was a little bit upset, and she told we'll sanction only 2 seats. Then sir was like, no, you sanction 3 seats, whatever you want, we'll send it in courier to CMC Vellore, and that's how they got sanctioned for 3 seats for MD radiotherapy. So that is one thing. And second thing is, my husband is a surgical oncologist attached to Tirunelveli Medical College, and he often used to tell me, so whenever I go to tumor board meeting, Dr. Rajkumar sir and Dr. Prabhu sir used to always ask, sir, நாங்க வந்து மேடத்தை நிறைய தடவை பார்த்ததோட வந்து உங்களை தான் டெய்லி பார்க்குற மாதிரி ஆயிடுச்சு. So that is the lighter side of Tirunelveli Medical College and my association. It's like an extended family. So thank you, Professor Devanayagam sir, for this opportunity. So coming to the topic as such, so TNT is definitely a very interesting topic, and we all know. So when I started my postgraduate days, it was mainly the neoadjuvant treatment concept of rectal cancer came into vogue, and from that it has revolutionized. Every year there is a new concept coming in rectal cancers. So first coming to the epidemiology, so we all know that nowadays rectal cancers are increasing, especially in young adults. Many patients are coming. This is mainly due to their lifestyle habits and also their daily professional habits as well. So coming to the evolution, so the standard treatment in those days, that is 10 years back, was neoadjuvant chemoradiation followed by surgery and then adjuvant chemotherapy. So but what was the limitations in this standard treatment which switched over to total neoadjuvant treatment? Was mainly the poor impact on the distant control rates. So inconsistent patient compliance, especially after a surgery, because when you give neoadjuvant chemoradiation standard treatment and then the patient subjected to surgery, it's a lot of morbidity and wound healing and other things. So completion chemotherapy was very difficult, and low rate of PCR, around only 10 to 15% when you give a standard treatment regimen. So this slide is mainly for the postgraduate. So how the rectal treatment evolutionized. So first was the Dutch colorectal cancer trial, where the concept of neoadjuvant chemoradiation came into force, and the meta-analysis which proved it is efficient was the German rectal cancer trial, which compared preoperative chemo-RT versus postoperative chemo-RT, where preoperative chemoradiation was beneficial and the patients completed treatments. So from 10 years down the lane, all of us practice neoadjuvant chemoradiation in rectal cancers. Then what happened? Then came the Stockholm trial, where they started comparing short course RT followed by delayed surgery is comparable to long course RT. So that trial also was useful. It showed that short course RT and long course RT had similar results. Then came the concept of total neoadjuvant therapy, where the Rapido and Prodigy came into force, where you complete the total chemotherapy and radiation before you subject the patient for surgery. And nowadays concepts are coming to include this genetic evaluation as well as the role of immunotherapy. I will be discussing in the later slides. Then coming into what is total neoadjuvant therapy. So total neoadjuvant therapy is nothing but completing your standard chemo radiation, concurrent chemo radiation, and along with a complete course of chemotherapy before surgery. So why it has been proved to be beneficial, especially in locally advanced rectal cancers? It improves the disease-free survival. It creates a complete pathological complete response rate. So most of the patients you can put under non-operative management or wait and watch policy, and also the chemotherapy completion rates are very higher in the TNT arm. So here is just a slide to show what is meant by induction chemotherapy, where you give few cycles of chemo and then give standard concurrent chemotherapy followed by surgery. In consolidation, you give chemo radiation prior, then you subject the patient to chemotherapy followed by surgery. So why do you want to intensify the preoperative therapy? So what all these trials like preoperative standard chemotherapy showed that is, though the local control rates were very good with neoadjuvant chemotherapy, the distant failure rates, especially at 5 years, was increased. So in order to reduce the distant failure rate, this concept of additional consolidation and induction chemotherapy came prior to surgery. And especially it was beneficial in very high risk tumors and bulky primary tumors. So anything you want to change the concept, there must be evidence to speak. Why are you changing the concept? So this slide is very important. So how the concept of TNT came into force. First it started with the Polish trial, followed by the Rapido, Prodigy, Stella, and discuss each one of them. And now you have few immunotherapy trials and also trials comparing triplet regimen versus doublet regimens in chemotherapy are also coming into force. So first, what did the Polish trial compare? Was the short course RT versus long course RT. So what it came to a conclusion that only the pathological complete response rates were improved, but the DFS and overall survival and 7 years results are out, there was no much difference in both arms. And then what did Rapido do? So mostly all T4 tumors were included, and short course RT followed with consolidation chemo was tried versus standard regimen arm. Similarly,
Prodigy, it was fall fix free with chemotherapy and then surgery versus the standard arm. So what these both showed was mainly in short course RT there was increase in the loco-regional relapse rates at a long term. But there was reduction in the disease-related treatment failure and distant metastasis rate, and the overall survival was not beneficial in Rapido. But the Prodigy trial, the 7 years, I think, 7 years results have come, which showed a minimum overall survival benefit in the neoadjuvant chemo arm. Then came the Stellar trial, where it compared the short course RT and standard
chemo radiation along with consolidation followed by surgery, and this trial also showed short course RT is better, and similarly overall survival benefit showed a minimal improvement in the TND group. So this is the comparison between the three studies. So mainly the concept was, especially you should look into the pathological complete response rate and how much downsizing of the tumor is being done. Then especially for the surgeons, it is the CRM. So only when you are able to get with a negative CRM, the surgeon will be comfortable in operating. So these all the three trials showed a very good improvement in all those things. The only hitch here is overall survival benefit was only shown in very few trials and not in all the trials which underwent TNT. So the evidence to self TNT is the 3-year metastasis-free survival was improved, increased PCR rates from 12 to 27%. Similarly, the completion chemotherapy rates were very, very high, at around 81% when compared to the standard arm of 70 to 75%. So now you are clear with the concept that TNT definitely has a role in locally advanced rectal cancers. Then when do you want to go for an induction chemotherapy, or when do you subject the patient for a consolidation chemotherapy is the question next to be taught. So then came the AROI randomized trial, which compared in one arm the induction chemotherapy, then other arm the consolidation chemotherapy. So for a radiation oncologist, it is always better to go for a consolidation regimen, because once you complete RT, then chemo, the morbidity will not be there. So for us, consolidation regimen, and even I am very comfortable in treating a patient in consolidation regimen rather than a induction regimen. Similarly, consolidation resulted in better adherence to radiation, as I have already told, but worse adherence to chemotherapy, and PCR rates were also better in the consolidation arm. An induction regimen when you would like to go is with patient with increased risk of micrometastasis and in really high risk tumors like extramural venous invasion or lymph node involvement, because by the time you complete your RT, sometimes the patient may develop metastasis. So in such cases, you prefer going a induction regimen than a consolidation regimen. So these are the evidences for TNT and induction when to give and consolidation when to give. Next, we'll go for the wait and watch policy. So what are the trials which support the wait and watch policy in recently in locally advanced rectal cancers? So there are so many trials where many institutions have been talking about this wait and watch policy, and even in our scenario also, nowadays we are mainly going for wait and watch policy. So the most important trial is the OPERA trial. So any one of the PGs, can you tell what is the expansion for OPERA? It's very easy. Organ Preservation Rectal Adenocarcinoma trial. So it is a OPERA trial where they compare standard regimen along with chemotherapy, and then the patient was put up under 3 tiers surveillance. So these 3 things you should include. Once the patient has completed the treatment, you should go for a digital rectal examination, you should go for an endoscopy, colonoscopy, and then a MRI imaging. So what does it tell? If there is complete response or near complete response, you go for a wait and watch policy. If there is incomplete response, you go for a surgery. So this is the schema where patient is subjected to either induction or consolidation, and which group of patients go for a wait and watch policy. And this trial definitely proved beneficial. More than 50% of the patients with locally advanced rectal cancers, they were able to preserve organ preservation because they were able to achieve complete response in more than 50% of the patient, which is statistically significant. Similarly, the local regrowth rates at 3 years was very, very less. It was only around 10 to not even 10%, I think. So the concept of organ preservation came only from this OPERA trial, where you improve the quality of life of the patient. Similarly, the surgical morbidities like bowel functions, bladder functions, sexual functions are also very, very minimized because you don't send the patient for surgery. But so this was the oncological outcome. Majority of local regrowth occurred in 3 years within the rectal wall. So this is very important because you can salvage the patient even after 3 years. And 80 to 95 were salvageable, and 5-year overall survival was around 85 to 87%. But what were the challenges in organ preservation was the risk of recurrence, because strict monitoring is very, very essential, because you have to educate the patient, you have to give counseling for proper every colonoscopy, MRI, DRA, because people coming from very remote area, the intensity of the follow-up will be very difficult. So all these things you have to keep in mind before you go for an organ preservation approach. Then, being a radiation oncologist, we must know how to improve further in a organ preservation manner. Came the OPERA trial, where they added brachytherapy boost along with RT, and that also improved the 3-year organ preservation rate from 59% to 81%. So this is how the boost 45 gray external beam RT was given, along with 25 to 30 gray of boost was given, and the patient was put under surveillance. So this is also another method for wait and watch policy. So this is the non-operative management which you have to know in locally advanced rectal cancers. Then how do you select the patient? So very, very easy. So whenever a patient comes locally advanced rectal cancer and you want to go for an organ preservation, so all this you have to discuss with the patient, whether you will come for proper follow-up, whether you will be able to do a MRI repeatedly, whether you will be able to do a colonoscopy, and all these, and depending upon the IQ of the patient, everything you have to consider. And if you want to go for organ preservation, today the standard of care is you preferably go for a long course RT, because long course RT along with chemotherapy and consolidation regimen at 5 years has a edge over short course RT, and this is proved. And similarly, when you want to go for a short course RT, when the patient is coming from a very far place, or he wants to finish off the treatment earlier, or when you feel the tumor is very high risk, like extramural venous invasion is there, and before you complete your long course, the patient may go for some metastasis. In such cases, you can go for a short course RT, and also scenarios like COVID, such scenarios in pandemic situations, you can go for short course RT. So this slide you have to remember, everybody must remember this. So as I have already mentioned, mentioned, long course RT has a edge over short course RT when it comes to the disease-free survival and distant control rates at 5 years. And this is proved here already. Then coming the concept of organ preservation now with immunotherapy. So docetaxel has shown a role. So nowadays, whenever ASCO also has recently recommended in T3, T4 tumors, so this is a very excellent paper. When you go read this now, you can clearly sort out which patients you have to send for RT and when early RT can be, early T3 A lesions where RT can be omitted and where immunotherapy has a role. So nowadays, what they are looking into is the MMSI and MMR. If it is positive, they preferably ask to go for immunotherapy, but I don't have any experience in that, so I'm not going to talk much about it. And I would also like from seniors from the floor to tell their experience about immunotherapy. So usually it is a total neoadjuvant treatment and then surveillance with a triple tier method like DRE, colonoscopy and MRA will definitely have a edge over in wait and watch and non-operative management for locally advanced rectal cancers. So now it has been evolved, like initially when I was a student it was multimodal, more toxic regimens, patient completion of treatment was very poor, especially see when I was a postgraduate I still remember when the patient goes for surgery and comes for adjuvant chemo, adjuvant RT, the patient will never complete adjuvant RT itself. So that was the scenario because a lot of morbidity used to be there. Now we are going for a bimodal and very less toxic and targeted treatments. So this is the stand today in locally advanced rectal cancers. So advantages are improved compliance, better tolerability, better PCR rates and early treatment for micrometastatic disease. Disadvantages, there are a little bit. Like long-term follow-up data is not available, only 5 years and 7 years data are available. And organ preservation, delaying surgery may cause tumor progression, role in early T3 tumors, so all this is questionable. Similarly, when you give chemotherapy and you complete all the induction and consolidation regimens, surgeons always keep telling that the treatment time is increased more than 12-15 weeks in such cases. It may impact survival. So these are the questions unanswered. And my experience is only very few patients I have. So what I have noticed in my clinical practice is most of the patients they lost to follow because whenever we tell repeated colonoscopy, MRI, the patient is not affordable. They tell I'll come in a week or something like that, and the recurrence rates were only less. And similarly, what I had experienced is patient when we do a diversion coloscopy initially, those patients they wanted to go for surgery rather than going for organ preservation because they were very uncomfortable with the bag and other things. So I think I have covered all these topics: evolution, what is TNT, what are the evidences which you have to know, and the wait and watch policy, opera trial, and treatment selection of cases. So the conclusion is TNT is definitely the preferred approach in high-risk rectal cancers. Long course RT is preferable when you consider organ preservation. Similarly, RT dose intensification by brachytherapy boost has also a role. Take-home message will be TNT means systemic chemotherapy and radiation before surgery, and all clinical T4 disease with involved circumferential resection margins, N2, lateral pelvic node involvement, extramural vascular invasion, definitely TNT is the standard of care. Thank you.
Questions from the floor.
TNT you are giving, mainly we are taking only for adenocarcinoma. We are not talking about the variant type. Pathological variant, if you are having pathological report as different, not adenocarcinoma, that will not be, I think TNT will not be a good choice in those cases.
Yeah, definitely, ma'am. So that's why when you want to go for a non-operative management, they will ask for a triple tier examination, like digital rectal examination, a colonoscopy and MRI. And in MRI, extensive MRI is there. So there are so many features which highlights like lateral pelvic node involvement, presence of LDSI, and then extramural venous invasions, mesorectal fascia involvement, the depth of invasion. So all these things, everything has to be looked into, and then the patient should be subjected for treatment accordingly. So it should be individualized.
Thank you.
people have a complete response with the.
Not available in India.
Oh.
Multi-Speciality Hospital, Tanjore.
Good afternoon, everyone. The next session will be a panel discussion on pediatric cancers. The moderator for this session will be Dr. Karthika, Sri Ramakrishna Hospital, Bangalore. I invite the panelists for this session, Dr. Deepak Joseph, AIMS Rishikesh, Dr. Ramanaya K, Cancer Institute, Adyar, Chennai, Dr. Maniratnam, Meenakshi Mission Medical, Dr. Maniratnam, MMHR, Dr. Isham K.S., HB Hospital, Chennai, Dr. Kartikeyan Perumal, Dr. Ramakrishna Memorial Hospital, Chennai, and Dr. Satish from Equitas Hospital, Chennai.
topic they gave me was pediatric tumors. So that picture of mine is painted by a craniopharyngioma child. So I'm very happy to give it for the panel today here. So that's why I gave that picture of mine. And pediatric tumors, I know we don't do it daily, day in and day out. So we are going to do it faster. Medical oncologist, please. Yes, yes. Okay. Thank you. Thank you. So we'll move on to the case. A 3-year and 8 months old child came with hematuria for a duration of 1 week. And of course, I'm not going to tell you the whole set of investigations. We just proceeded with CT abdomen and pelvis. And right kidney measured, the size is mentioned there. And let me show you the picture. This is the picture of the CT abdomen. And yes, what next? Anyone please? Possible, probable.
So I will start with clinical examination as well as basic blood investigations.
That's all done, doctor. CT is done, and you have a lesion there. Let's be straight. So we have a diagnosis. Yeah.
A young child with solitary kidney mass, most probably it's a kidney tumor, most probably Wilms tumor.
Yes.
Other differential diagnosis.
The same, and then underwent with right radical nephrectomy with node sampling on 27/9/24. Biopsy came as Wilms tumor, favorable histology. I tell you the whole biopsy, renal vein involved by the tumor, and the extension beyond renal capsule by viable tumor, and LOH nodes were negative, and the patient had final diagnosis stage 3 Wilms tumor without LOH. LOH is loss of heterozygosity for 1p16q. So what next, doctor? Radiation oncologist followed by a medical oncologist, please.
Is there any tumors operatively?
No.
So, straight surgery, I think we should go with chemotherapy. Within 14 days, because of stage 3 favorable histology, we should go with flank radiation. We have various protocols like COG, COG both. So, most of the time we use hybrid protocols. Mostly we will prefer 10.8 to 14 gray to the flank radiation, and we will continue chemotherapy.
When should radiation be started? Is it 14 days or?
Ideally, as per NCCN recommendation, it should be 9 to 14 days, which have good outcomes.
So that's the main thing which we wanted to insist. So what has to be done in a Wilms tumor child, especially on favorable stage 3. So this, of course, it's all from the textbook, the postgraduates. It's how to stage the tumor, and management is very important. How to go about adjuvantarity. Can you tell me the timing, dose, fractionation for radiotherapy, please?
Yeah, 10th day, not beyond 14 days.
Ideally.
Yes,
ideally. Yes, because most of the situations they do send it on the right time, but sometimes we have the problem of facing it a little later. But it's never beyond 19, and day 14 should be the maximum, and it is ideal to do on day 9 or day 10. And what will be the dose, doctors?
If it's COG, it's 10.5. If it's SIOP, it's 25.2. The dose. 10.5. I mean, we usually follow COG protocol. So 10.5 grade to the
yes,
plan.
Because now we have moved from NWTS 4 and 5. Now we have come to the COG studies, and we've been following the COG protocols. So very important is how do you time all this, and then we have to know about the adjuvant chemo as well. So now we have the risk stratification. This is all also given. You can study straight away from the textbooks, but it is important how to risk stratify these tumors. So what group this falls into? So when you see it is stage 3 without LOH, that it falls into standard risk favorable histology Wilms tumor. So the protocol what is followed in COG is clearly given. Now we have to know about the chemotherapy protocol. Sir, please, chemo, adjuvant.
So forget that. Forget.
Wilms tumor, stage 3 favorable histology. So shall I go ahead, sir?
Yes,
Okay,
yes,
fine. So it is after the radiotherapy guidelines, we have to know this child definitely needs adjuvant chemo as well. So the COG studies AROI-0532 is the protocol which we rightly follow nowadays. So the main objectives are for very low risk, the objective of the study was to assess for very low risk patients. Surgery and follow-up alone will have 4-year recurrence-free survival of say 85% and more than overall survival 95%. And what is the to continue whether the excellent outcome of these patients is continued throughout and improve the current 4-year recurrence-free survival of stage 1 and 2 ones without adding doxo to the standard regimen. But what we are actually doing is we are giving adjuvant chemo with so DD4A, which is vincristine, actinomycin, and these two main drugs. And then we also add doxorubicin with the 3-drug regimen is the best, and that is the adjuvant chemotherapy which is standardly followed. And another one, the chest X-ray of this child is normal. Of course, it's actually a hypothetical question, but we wanted to know whether to just make clear when will you add a whole lung irradiation. So if at all you pick CT in the CT scan of this child, if you are picking some lesions, doubtful, is there a role for WLI, radiation oncologist?
Actually, that is a bit controversial. Nowadays, if there are lesions after chemotherapy, initial chemotherapy, CT wise, if you are finding the lesion, better to go with, if based on age, if less than 12 months, more than 12 months. Less than 12 months, we can consider 10.5 gray whole lung RT. More than 12 months, we can consider for 12 gray of a whole lung radiation. That is the recommendation. But a lot of studies are upcoming. They mentioned that even though chest X-ray does not show any lesions, post chemotherapy CT chest has lung nodules. Some studies just they are observing only to avoid the lung toxicity, because one study reported that post radiation lung causes a lot of morbidity. So still that is a bit controversial.
Yes, definitely, because if the chest X-ray is normal and only the CT is picking up the lesions, there are trials to say that we can still withhold the whole lung irradiation, and with chemo, if it is disappearing, it's fine. But we have the protocol for the same, and if you have the 6 weeks reassessment after chemotherapy and there is complete unfavorable histology, if you have complete disappearance of lesions, we don't add. But if there is no only partial response, we do add a whole lung irradiation, and the dose is usually 12 gray 8 fractions. So this is what is followed, but there is no survival difference if you are going to have a normal chest X-ray and your CT is alone picking up the lesions. So that's why we are not adding in that situation, and they usually show complete response with chemotherapy. So those kind of patients, and initially presenting with a lung lesion, then we have to assess according to whether it is favorable or unfavorable. Favorable, you assess at 6 weeks, complete disappearance, you just wait and you continue with chemo. And if there is only partial response, we add. For all unfavorable, we definitely add whole lung irradiation. That's the protocol which is followed today. We are moving on to the case 2. 6-year-old boy presented with 1 episode of giddiness and fall with a 2-minute LOC. Headache on and off for 6 months and with weakness of apparent lower limb. He presented to our neurosurgery department, and then the CT brain, which was done in 23, large 10 cross 8 tens, enhancing solid mass with mass effect and midline shift. MRI done, again showed, see the lesion size, you can see it is so huge, 10 cross 7.8 cross 8.3, showing heterogeneous enhancement with contrast. So what was the radiological probable diagnosis? Was a PNET or a pediatric meningeal supratentorial hemangioperiostomy. But what next, doctor? With such a big lesion?
So first, after the MRI is done, usually pediatric meningeal is very rare. PNET is common. Sometimes high-grade gliomas are also common. So better to go ahead and remove as much as possible. Especially when there is mass effect and midline shift, there may be some amount of thalamic involvement. So hence, 100% removal is not possible in all the cases. And whatever we can remove, safe maximal resection, and then for histopathology.
Yes, that's a dictum in neuro-oncology. So first what we have to do, we have to proceed with a surgery. Underwent right parieto-occipital craniectomy and subtotal excision of the right parasagittal parieto-occipital SOL. That was on 7/8/23. And biopsy we also sent it to demands. It was glioblastoma, NOS, CNS, WHO grade 4 with key 67 was around, I think 25%. So what next, please?
Actually, glioblastoma itself in this age group is quite rare. We call it as high-grade glioma.
Yeah.
And there are two possibilities, especially when if it is little elderly kid, we may think of hemispheric gliomas. But in this old kid, if the mass is little bit on the midline, we can think of midline gliomas. Otherwise, if it's high-grade glioma, we just go ahead with concurrent chemoradiation followed by adjuvant temozolomide. MGMT methylation has to be done. And to add to that, we can actually do NGS testing also to see for aggressive markers such as CDKN, 2A, 2B deletions and EGFR amplifications, so all those things.
Definitely.
Because such a big tumor and how much ever we resect, we'll be definitely facing all these necrosis and other things later on.
Definitely. So again, and I think it is only the surgery, you can see it is only in 2 to 3 weeks he presented again to us. We repeated an MR that was showing a significant residual lesion. So so with this we took him for, that's the lesion when he presented to us. Maybe on, so adjuvant
radiotherapy.
Please.
The dose generally 54 gray, madam, 1.8 gray per fraction. Dose beyond that is not recommended as per NCCN, recent NCCN. The volume is the GTV with adequate CTV with PTV margins 1 to 1.5 centimeters. The technique will prefer high precision techniques better than the 3D, madam. Chemotherapy, yes, there is a role concurrent as well as adjuvant temozolomide is the role, followed by lomustine if needed.
Some more inputs on chemotherapy from the floor. Yeah, please. Because high-grade glioma, pediatric age group. Mic kekranga. Excuse me. Mic pudunga.
Rajesh.
First thing is Dr. Rishad said we have to roll out NGS for in this age group. Definitely we may pick up some kind of mutation. We are seeing last few years 5-6 cases CMRD associated high-grade glioma. For those patients you should avoid temozolomide because it will cause hypermutation. And CCNU we can consider as a adjuvant setting, and some patients they will respond for immunotherapy also. Second thing is one more mutation, antric mutation. So those patients also having like targeted and anti-antric therapies also there. It's also common in pediatric tumor.
That's what we were thinking, that we are extrapolating the adult protocols of temozolomide, and we can, just like that, we cannot take temozolomide taken for granted. It's not given for all tumors. So we have percentages like molecular analysis is coming up for all the neuro-oncology patients. So here also we have to decide when to give and when not to give. That is one thing, and of course the newer drugs, a lot of newer drugs are on trial. I think today Rajesh enlightened me that there is a new drug which is approved on one for by the FDA for the pediatric glioma. So there are a lot of new drugs and trials coming up. That's very important, that how we are going to help, but understand high-grade glioma has a very poor prognosis in pediatric age group. So prognosis for high-grade glioma in children is very poor. Median time to progression is only 10 to 11 months. Usually factors affecting influencing the outcome will be location. See, our child had the extension driven corpus callosum and thalamus. So a very important prognostic marker is completeness of the surgery. And usually younger age group fare better here, which is contrast to when other tumors when we see. And of course, whether it is AA or GVM, there is no survival difference in pediatric age group. So put together, they are considered as high-grade gliomas of the pediatric age group. And more important is their the MIB index, which is actually giving at least reasonable prognostic indicator. So these are all the important things which we have to remember when we are handling high-grade glioma children. Third case, 9 months old baby, one of twin babies, 2 boys, and one of the twin boy presented with white reflex and leukocoria of right eye. Diagnosed with retinoblastoma group B. I've mentioned the international classification here. I'm not using RE. So that's the recent thing which is changed in retinoblastomas. So it's a group B retinoblastoma. What next? I'm sorry, I know these are more practices done by the ocular oncologist, but still this case is presented here because a lot of centers don't do plaque therapy. We are one center, we are referral for retinoblastoma in Coimbatore. We have a tie-up with Arvind, and we have a dedicated ocular oncologist who is handling retinoblastoma, and we do plaque therapy for retinoblastoma children as well. So that's why we have presented one case here, so that at least you have an idea how retinoblastoma is treated nowadays. So this is group B, that means it's ocular confined. Can you just add on?
In this case, if feasible, we can go for focal therapy. Otherwise, chemo reduction. I mean, start with chemotherapy followed by a focal therapy. Whether it could be a cryo or laser or plaque therapy.
Exactly. So nowadays, retinoblastomas are handled most with local therapies because it has been always saving the life first in all kind of cancers, and now it is organ preservation. So when retinoblastoma, we were students, it's like we've been seeing most of the kids who come with enucleated eye orbits, we've been treating, but now it is not the scenario. So we are trying to protect the eye as well, and the vision, whatever preservable vision there, we are trying to preserve the vision. So for group B, this patient, I mean, this is the international classification of retinoblastoma which I have projected. So it is, B means it is usually macular retinoblastoma, larger tumors. What they did, all these are handled by ocular oncologist outside, and they come only for radiotherapy to us, but we know the protocols because we've been doing it for many years. So this child had 3 cycles of IAC, that is intraarterial chemotherapy with melphalan and topotecan, usual standard regimen. He had 3 cycles, he had very good response, the parents were very happy, again lost to follow-up. This is very common in retinoblastoma. So what next? Again, and the child, and these are all, this is the, let's go back here, yeah. Again after, so again they came back. I'm sorry, I moved. I think I'm going the wrong direction. Sorry. Is it there? Yeah, thank you. So after this, the child, we lost him for follow-up, and then after 1 year, again he had a recurrent lesion and presented back. Again, this time it was group C macular retinoblastoma. We have to do a metastatic workup. So generally, what are the metastatic analysis we do is, doctors?
We will usually do HCT and then CSF testing to see whether there is any seeding, and then bone marrow exploration, which I already mentioned.
Yes. That's very important because that's a common site of metastasis in retinoblastoma. Whenever there is a progression, we try to rule out, and then we do the distal metastatic workup. And then the doctor restarted the same cycle of IAC with same drugs. Again he had 2 cycles. Again he had very good response. Again lost to follow-up. Again he had a further fallen vision. Came back now with group D disease. Group D means it is you have started with vitreal seedings. Yes. So what next? Yes.
One option is chemotherapy.
Yeah.
And then if we are preserving, then we can think about the external beam radiation. Otherwise, he has to go for enucleation.
Exactly. So here it is now we have to know what is the vision. Are we going to preserve the vision? If there is a useful vision in the eye, we are going to preserve the vision. At the same time, we are going to prevent further deterioration in the progression of cancer. Then it is worth doing any kind of preservation. So. And the child underwent enucleation on 14/12/24. The biopsy came as retinoblastoma tumor cells which are seen on the middle and outer border of sclera. The optic nerve choroid posterior segment nil tumor. So now what next, doctor?
We have to sterilize the area, ideally external beam radiation.
Exactly. So now it has become an orbital. That is, you have to do the concern is you have to eradicate the microscopic disease also. So surgery is done, and then we have to proceed with EBRT. So patient is now referred for post-op RT, and then we proceeded with EBRT. Now again, so these are all the indications, especially group D and E. We cannot, we still have a role. We still have a role in retinoblastoma or radiation oncology, because we've been thinking that we are giving it to the medical oncologist and to the ophthalmologist. No, we still have a definitive role in group D and E, and if cut end is positive and there is a risk of spill into the orbit. So whenever there is scleral involvement, we suspect a microscopic deposit in the orbit as well. And whenever there is a recurrent and stubborn disease, sometimes it will not be amenable for any kind of local therapy, even with that is another, and when you suspect any kind of metastasis, we still have room. So the new PERIS for the postgraduates, the new PERIS retinoblastoma topic is very good. I think the new means the latest. So they have evaluated the RECIST criteria of retinoblastoma, how you have to assess the response to chemotherapy, the local chemotherapy, and what are the indications and what kind of radiotherapy has to be used where. So the tableau column is very clear. You can go back and refer. Yes, those techniques and of RT, please.
Usually from 45 to 54 gray, but an average of 50.4 gray. And wherever possible, higher end techniques such as IMRT or VMAT is preferable. Proton definitely has a role, especially in reducing the side effects such as facial aplasia and other optics nerve side effects. But only thing is, dose fall off towards the optic chiasm has to be very meticulously controlled because it's an unilateral retinoblastoma. Plaque therapy definitely always there's an indication for that.
Yeah, I just wanted to ask him because he has exposure to protons, so that's why. So proton is also coming up when you have a stubborn disease, and the dose when you have 36 to 45.
Got exposed to proton?
No. So the dose again, 36 versus 45. There was a decade before we had to discuss with the MSKCC because our ocular ophthalmologist was trained in MSKCC. So Dr. Beryl, he used to give lesser dose when it is a stubborn confined dose to ocular retinoblastoma, but nothing which crosses the sclera. He was very clear. So our ophthalmologist used to tell, madam, reduce the dose because we are ending up with vascularization like glaucomas and severe morbidity because of higher doses. We tried in between, but we felt it is not okay. So because our patients is not like their patients, their screening is very stronger, but sometimes our patients lose to follow up and then it's a stubborn disease. They progress faster, so it is not the same biology. So what we don't cross 45, generally we don't give 50, we make it 45. So it is always 45 standard if you are going to do a post-enucleation orbital treatment. And 36 we are not doing at all now. We did it only for a few years, and then we collaborated with the MSKCC people and they said they are also not giving for anything which is crossing the sclera. It's 42 to 45 gray. So it is very crucial to know what is the dose which is delivered now. And of course the volume of radiotherapy. It's very important whenever you have a cut end of optic nerve positive, you have to treat up to the chiasma. In this maybe we are doing it for 2 decades now, I had one isolated chiasma failure. Because those days our margin was not enough. So we didn't have a dictum of these kind of volume descriptions. So after that in the last decade, like we never had a failure because it's very important that you have to cover the chiasma in patients where you have optic end involvement. Otherwise you will have an isolated like cauliflower thing which is popping out from the chiasma, which is very, like you will feel very terrible because these are all highly curable cases. So it's very important how you volume and decide the radiotherapy volumes. So what advice you will give for the other twin, because it's a twin child?
Screening has to be done. Genetic testing has to be done for the sibling child, for the twin child, as well as if the parents want to get one more child, then those child has to be undergo genetic testing.
Refer to the ophthalmologist.
Okay.
So our ocular ophthalmologist, anywhere it is followed by the ophthalmologist, they have a screening protocol. It is very mandatory for you to advise there is a screening protocol and send them back. It's very important because I'm not going to tell you the screening protocol here, but it is very important. That's what I wanted to insist. Shall I do the 4th case or time's up? You can do the 4th case? Yeah. Time is up? Yeah. So I want to stick on to the time, please. It's fine? Thank you so much, because I wanted to do only the common tumors and retinoblast, and I thank KK because he was insistent what cases he wanted, and he gave me a lot of valuable suggestions and ideas. Thank you so much for the organizers who gave us this opportunity. Thank you. And the panelists, thank you.
We thank the team for the intense and electrifying discussion, marking the occasion with mementos. We invite the chairpersons to honor the moderator and panelists.
Thank you, sir. With the dynamic discussions concluded, we move forward to our
Hello. So, I think all of you have woken up from the postprandial stage. We will have a more difficult topic. Genetics at the bedside, personalized cancer care in the genetic era. I welcome Dr. M. Pradeep Kumar, Genome Center for Genetics and Diseases, Coimbatore, to present this speech.
Respected chairpersons, dear dignitaries, thanks a lot the organizers of AROI-TNPY for this wonderful meeting and allowing me to be a part of it. So I'll make this difficult topic as interesting as possible. So genetics at the bedside, how is it going to help you in the management of families with cancers? So genetics, we know is cancer, we know is a genetic disease, whether it happens in the cellular level or in the blood level. So there are uncontrolled multiplication of cells, and these multiplication or cell growth, development, all these are governed by genes. These genes are faulty, they are not working well. Because of that, there is uncontrolled multiplication. So it is a genetic disease, and the genes responsible or these oncogenes, tumor suppressor genes or DNA repair genes, you all should be knowing about the mechanism of their functioning. We broadly classify these cancers into two types, somatic and germline. So most of the cancers are somatic, constitutes about 90%. Around 5 to 10% of the families can have germline mutations. Though they constitute a minor group. They have different management aspects, surveillance protocols, and also the recurrence risk is a very, very important point we have to note. Once you find out a germline mutation, you can prevent cancers in potential family members. So somatic cancers, they occur at the cellular level. They are not inherited. They are confined to that organ, to that cell line only, and it is not in the blood. It will not be inherited or transmitted to the next generation. Whereas germline mutations are found in the blood, they can be inherited, and their inheritance pattern, most of the cancers are about in the autosomal dominant group, and the recurrence can be up to 50%. So this is a major difference we always consider. And most important thing is, because somatic cancers are confined to one cellular level, one organ level, if it is not metastatic, there is no significant risk for other organs. But again, if it is in germline, any other organ can be involved. It depends on the gene involved and the mutation also. So I'll discuss about germline mutations first. So when we talk about germline cancers, we cannot leave this actress who went ahead, who proactively went ahead, did her BRCA testing and found out her carrier status, that is pathogenic status, and she went ahead with prophylactic surgeries. She knows that her mother and her aunt had ovarian cancer and breast cancer. Because of that, she did, and it woke a significant response from the public. Everybody got aware of this particular entity, and they all started testing for them. Breast cancer in India, there are 1.5 lakh Indian women who are diagnosed every year. If you extrapolate to 5 to 10%, minimum of about 10,000 women would have germline cancers which are missed. That don't start with that woman, that involves her offsprings or her siblings also. So who should be tested for inherited cancers? We follow many recommendations, particularly NCCN guidelines and ACMG guidelines. So we start with the family pedigree whenever we evaluate, and if there are family clustering of cancer types, so all the generations somebody is having cancers, more than 3 first or second degree relations with breast cancer, or more than 2 affected individuals but at least 1 diagnosed less than 45 years, more than 1 case of ovarian cancer, 1 close relative with breast cancer, 2 breast and ovarian cancer, all these permutation combinations are there. But again, if you draw a pedigree, if there are multiple persons who are having cancers, then that is a red flag sign. There are many other recommendations. So early onset breast cancers, less than 45 in triple negative. If it is triple negative, less than 60 is the age cutoff. Male breast cancer at any age, high grade serous ovarian cancers, colorectal cancer, we have indications. Endocrine cancers, particularly to rule out MEN. So prostate cancer with Gleason score of more than 7, multiple primary cancers in one individuals. One primary cancer, you treat it, he is getting another primary. Hereditary cancer syndromes with some neurocutaneous markers, they are potentially precancerous conditions. In general, several first or second degree relatives with common cancers or related cancers. 2 family members with same rare cancer, unusually early age of onset, bilateral or multifocal tumors in different systems in same individuals, all associated features of cancer syndromes. All these families, they need genetic evaluation. Guidelines, concepts of genetic evaluation, we always start with the person who was affected. So there lies that unique code. With him or her, the unique code you have to identify. That unique code can be rechecked in all other family members. You can literally split the whole family or the extended family into 2. Members who are carrying the mutation, members who are absent, and the members who are carrying the mutation can get into the surveillance protocol for that particular mutation. Members who don't have that can relax. At-risk individuals should be offered genetic testing. The result should aid at the in childhood cancer testing if the mutation is or the cancer is likely to happen in the childhood. BRCA, we don't recommend childhood testing itself. We don't recommend prenatal testing also because these are not childhood cancers. But again, TP53 mutation, Li-Fraumni's syndrome, we may need to check for the children also at the early age. So children should be tested only if the malignancy can develop in the childhood. That is, I am telling about recheck. So what to test? So we are convinced that we have to test this family and we have to test for germline mutations. What to test? Is BRCA1, BRCA2 is enough? No. So there are so many studies which shows only 60 to 70% of the cancers, particularly breast cancers, can have BRCA1 and BRCA2. There are so many other genes implicated with that. So I don't stop with BRCA1 and BRCA2. So we go ahead and do all the genes, germline cancer genes which are identified. We go do it as a panel, or even whole exome sequencing is good enough. Here you are sequencing the whole genes. Not only the BRCA1, BRCA2, all other genes which are implied to that particular cancer. So there are so many gene abnormality. Risk assessment for at-risk family members, the siblings of this genotype, the mutation is fitting with the phenotype of your patient. If it is fitting in, then look for some family members who are having the same disease. You can recheck the mutation in them. and if the mutation is found, probably that may be the mutation running in the family. If the mutation is not found, since two sisters, breast cancer, one you have tested, one VUS has come, you can check that VUS in this other sister, and if she is carrying that, maybe this may be the mutation. If not carrying, then you have to look for some other mutation. This is not the mutation running in the family. Functional studies or family segregation studies, next level genetic testing, whether you have missed some deletion duplication analysis, or we have to wait and watch. Sometimes this mutation can become significant over a period when it gets reported all over the world. So we have to wait, reanalyze after a year and then give the results. Till then, definitely there will be an anxiety part of the family, because they cannot discard the result, they cannot take this result and move forward also. So all these risks are involved, but we have to explain this a bit before doing the testing so that the family will be prepared. And once the results comes, you tell them, yeah, I'm going to follow up. Don't take this as positive, but you have to be under my follow-up. I will tell you what has to be done in the future. So we have to own the responsibility at that time. Reliability of the labs matters the most, because there are so many labs available now. Previously there were no labs. We were requesting various abroad labs. Now everything is in your doorstep. And remember, all labs are not doing uniformly well. There are so many false results we are getting, and the reliability of lab, competence of the bioinformatics team, the team who is handling the reports matters the most when you get the genetic results. So 52 years female, there is a family history of cancer, and HER2 negative. She had breast cancer and the mutation was found, BRCA1. So this is a simple family. We have found out the mutation. Another family, 30 years old, invasive ductal carcinoma, no family history. Of course, 30 years, young age, definitely we'll go ahead, we'll do the testing, and we have found out the mutation. How are we going to apply this? So she has a sister, elder sister, 34 years, she is asymptomatic. She was tested and this mutation was checked, and she was found to be positive. So we made one diagnosis in a symptomatic patient, and the same family, there is an asymptomatic person who is carrying the mutation. She also needs a surveillance protocol so that we can pick up any cancer early in her and treat her completely well. So 3rd degree consanguineous colonic polyps, biopsy showed adenocarcinoma, family history of colonic cancer. She is the product of 3rd degree consanguineous. I am expecting a homozygous result. It is a autosomal recessive disorder, MUTYH, and we got this result. So the same way, another colonic polyp family, and we've got this autosomal dominant mutation, APC gene. So once you identify this, protocols, surveillance protocols for this person, and extended family members search for this particular mutation, is found to be positive, put them under surveillance protocol again. So another family with 16 years old with neurofibromatosis made this diagnosis, and the similar diagnosis was made in a 23 years old pregnant woman. So 23 years old pregnant woman came with a 10 weeks of gestation. There is a baby inside, and we know potentially that baby can get 50%, neurofibromatosis about 50%. So mother was not tested. 16 years, she had cerebral lesions, so we have tested, found out the mutation. Obviously, in next generation we are going to avoid this. But 23 years old mother with plexiform neurofibroma, untested, came with an ongoing pregnancy of 10 weeks. We have very limited time. So we did the mutation and we found out she was having this neurofibromatosis, pathogenic mutation. It was checked in the fetus. Fetus was negative for the mutation. So we know this fetus is normal, doesn't have neurofibroma. So this is a family, another family, not unfortunate family. Mother has plexiform neurofibroma. She has 3 years old child with multiple caveolin lesions, and 9 months old baby with multiple caveolin lesions. So neurofibroma, if we identify, we can prevent by doing prenatal diagnosis. This is a very interesting family. So non-consanguineous couple, pedigree shows 2 childhood deaths. You can see in the pedigree 2 maternal uncles died in the childhood. So first baby of this mother was apparently normal till 10 months, had short febrile episodes, seizures, dehydration, died in 2 days. We don't know the cause. As pediatricians, we always think of some inborn errors of metabolism. 2 days, baby deteriorated and died. That should be the reason. Second baby had irritability since birth. On evaluation had Wilms tumor. Biopsy showed round cell tumor. Treated for the same. Deteriorated and died later. So this baby also died later. Genetic evaluation not done. DNA is not stored. So I have this family with history of 2 maternal uncles died in childhood, 2 babies died. One baby, we don't know the answer, other one has a round cell tumor, but no DNA is available. This family presented to us for pre-pregnancy counseling. They are very, very anxious whether to conceive or not. We are definitely they'll be worried because they lost 2 children, 2 babies. They presented with apprehension. The best person to test is index child. I don't have index child DNA. Index means who is affected. But however, the DNA was not available for any of them. We asked about the fallen right umbilical cord of the second baby, and luckily it was available. We extracted the DNA from the fallen umbilical cord, and then genetic analysis was done. We found out a mutation in SMARCB1 gene, and this causes rhabdoid tumor predisposition syndrome. So we know that there is a mutation, and that would have been the reason for all other the previous child's death also. Mother was tested and mother was found to be a carrier of this mutation. Then we know the recurrence risk for next pregnancy is 50%. Amniocentesis was done in the next pregnancy and fetus was found to be normal. Mother is put under surveillance protocol. So this is how we have to trace from somewhere, get some DNA, do the testing and recheck in the family, try to prevent in next generations. So for germline cancers, to conclude, 8 to 10% of cancers are hereditary or familial cancers. If you do a genetic evaluation and find out, specialized surgical medical management can be offered, proper surveillance protocol can be provided to them. We can prevent another family member being affected or getting a high grade tumor by doing surveillance protocol if they are positive. And we can prevent in the next generation also by prenatal diagnosis. So somatic mutations, I'll finish off in 3-4 minutes. So indications for somatic mutation, this is purely confined to one cell, one cellular line. So you are doing the mutation testing in the biopsy sample. So here from the blood whether cancer cells are there or not. So MRD positivity by doing cell-free tumor DNA analysis, if you find out something, it means that it may be a positive sign or it may be a false positive sign also. If it is negative, maybe you can relax a bit. So circulating tumor DNA analysis is the next level of surveillance in the future. So non-invasive method, take out some blood, filter the DNA, tumors of tumor DNA, and identify and give the risk evaluation. It is not like yes or no answer. It is high risk or low risk strategy. So detecting cell-free DNA post-surgery in colorectal cancers to predict relapse before radiological evidence appears. So we can get tumor-informed assays. Previous tumor mutation is identified, somatic mutation is identified. You can search that mutation whether that is present in the cell line or in the tumor cell line or not. Tumor agnostic is generic testing. If you don't have tumor markers or the previous mutations, you can check in general whether it is present or not. So also it is very, very effective in hematological cancers like acute lymphoblastic leukemia, AML, CML, colorectal cancers, small cell lung cancer and breast cancer.
Time is up. Please
last slide, sir. Last slide. Yeah. So personalized cancer care in genomic era, genetic profiling plays a critical role in personalizing medication, including immunotherapy. So improve safety, reduce costs and enhance treatment outcomes. Germline cancer therapy helps in prevention of a cancer in this particular patient and also the family members. ctDNA analysis, minimal residual disease also can be picked up earlier and sensitive detection. So personal cancer care in the genomic era is the way forward. However, its integration into routine clinical practice requires interdisciplinary collaboration. That is what I expect from you. Thank you so much.
Thank you very much.
There will be a lot of questions, I know, from all the people, but unfortunately they are indicating that the time is short. So, just I have only one question which can answer many of their questions together. Doctor, only one question. First of all, when you are testing the patient who has got this problem, and if you have found already it is only a somatic mutation and not a genetic mutation, do you want to further probe into it?
There is only somatic mutation. Do you still screen the family?
If the somatic mutation doesn't imply any germline mutation, then we don't probe into germline testing.
Otherwise, it will unnecessarily scare the whole family all the time thinking about cancer, and whatever we are thinking, we will become on the same thing. That's how they get another cancer.
Practical question. You see, you've been tested, say, suppose BRCA1 is positive in one of the siblings which we identified, and they refuse to do any preventive treatment. What are the chances of them getting a malignancy?
So that,
when is that probably they get? Because most of the time clinical practice, they are very fearful, as I said. So convincing them is very difficult to get testing.
So the penetrance is what we are going to explain to the family. Penetrance is not 100%. If you are having a mutation, that doesn't mean you are going to get the disease. So in pre-test counseling itself, we will tell them, if you are found to be positive, you are at higher risk than the society. Not you are going to get 100% cancer. So the penetrance is around 45%, 50%, 45%. So if they are positive, their chances of getting cancer is around 45 to 50% only. Another 50%, in spite of having that mutation, she will be normal. She or he can be normal through their entire life. So this is one thing, sir. Another thing is, so maybe if they are not proceeding with it, the clinical surveillance alone can be given, like that of the affected offspring, affected sibling, that can be offered to them.
I think other questions we can leave it to the tea time, because we are running short of time.
Just one question, sir. This is regarding retinitis pigmentosa. Now, when we do stem cell banking, cord cell banking and all that, when we retrieve that for the other child who has, does it really help if there is any treatment at the future?
No, ma'am. No. That stem cell storage is not proven to be useful.
Not proven.
Not only for RP, for most of the disorders.
So we do this.
We don't encourage, ma'am.
You're not encouraging.
We are not encouraging that. You are paying money and storing. No?
Yes.
The private stem cell banking, we are not encouraging. That is not useful.
No, about this. Thank you.
Thank you.
Thank you, sir, for the enriching this topic with your expertise.
Thank you, Dr. Pradeep.
May I invite the chairpersons to honor the speaker? We invite Dr. Srinivasan sir to give memento to the chairpersons. Thank you, sir. Moving on to the next session, SBRT in hepatocellular carcinoma. We welcome Dr. Janardina Kani, Kumaran Hospitals, Chennai, Dr. Pratna Roslin, ICC Neyur, Dr. Varadarajan, Medical Physicist, Wilroth Hospitals, Chennai as chairpersons.
Good evening. Welcome Dr. Kani Anand from JIPMAN to enlighten about SBRT and NCC.
Autosomal dominant silent.
Good evening to all. First of all, thank the organizers for the opportunity. So next 20 minutes, I'll discuss briefly on the SBRT main indications in HCC. Hope it will be useful for the postgraduates to write a short note. So this is the outline. You will see the epidemiology a little bit and staging and what is the role of RT in HCC and where RT fits in the algorithm, treatment algorithm, especially the SBRT, and then we will summarize. So this is the global burden as well as the Indian burden. In India, liver cancer, it accounts for almost 38,000 cases, ranking 11th in terms of incidence of new cases, and majority, nearly 80% of these liver cancers are hepatocellular carcinoma, which are often linked to infection with chronic viral hepatitis, which is either B or C. And this is the AJCC TNM staging, which is based upon the size of the tumor, the number of tumors, and then the vascular invasion, and whether lymph node mets is there or not, and then you have distant metastasis. Based on these parameters, the TNM staging is there, and along with that, you have the grade as well as the fibrosis score, which is for prognosis. And most important thing in HCC treatment is the liver function assessment, which can be assessed by various parameters, which will tell about the amount of good liver reserve which the patient has. So the most traditionally used system is the CTP score, and then we have now MEL score, and then you have the ALB grade. And CTP score, I think everyone should know as a postgraduate. There are 5 parameters which are included in it: encephalopathy, ascites, albumin, PTLR, and then bilirubin. Based on this, we have class A, class B, and class C. Class A is up to 6 points. Anything between 7 to 9 is class B, and then anything more than 9 is class C. And this is the BCLC staging system treatment algorithm, which we have latest from 2022, in which we have various stages, starting from very early stage to the terminal stage. And this staging, it is based upon 3 factors. One is again the size of the lesion, and then number of lesions, and then you have the performance status into account, and then the 4th one is the liver function, preserved liver function, which is usually assessed using the CTP. And when you look at the treatment armamentarium of HCC, we have various options. The main curative options include the surgical resection, and then the liver transplantation, and then we have other loco-regional therapies like ablation, arterially directed therapies, which can be TACE or TAR, and then we have the radiation therapy, including the SBRT, and then we have systemic therapy, which is the cornerstone in advanced diseases. So how to choose the treatment option? The treatment of HCC is complicated with the underlying disease which usually the patient has. So we have to be wise in choosing a treatment option after weighing the toxicity and then the benefits from those treatment options. So role of radiation therapy, traditionally when you look at it, was limited because of the fear or the risk of radiation induced liver disease. However, with the technological advancements, there is improved safety and efficacy of this EBRT. And it can be used as a single modality or even as part of a combined modality. And this RT, it can be either conventional or hypofractionated and SBRT, and now charged particles like protons are being used. And SBRT, as we all know, it is the delivery of high dose fraction with minimum collateral damage using multiple beams and with respiratory motion management techniques. So this is the algorithm. If you look at this, the BCLC algorithm, this is the 2018 algorithm. If you see from very early stage to terminal stage, you will not find RT in any of these treatment options. So we have mainly ablation, resection, or transplant, and TACE and systemic therapy in the form of sorafenib, and even best supportive care is included, but we do not have RT in it. So don't we have evidence or what is that? So when I try to analyze, you can find that this is the latest 2022 update of the BCLC. Even in this, you cannot find the RT in any of the treatment options. And when you look into the paper line by line, they have mentioned in cases where TACE is preferred option, even TAR is equally effective, they have told, based upon one study called as the Legacy study, which is a multicentric retrospective study. For SBRT, if you see, they have written one line saying that stereotactic body radiation gives anti-tumoral activity, but further prospective studies are needed to define its role. So then what role do we have? Do we have evidence or not? So when we look into the evidence, and I can find that radiotherapy, it fits into almost each and every stage of the HCC. Not starting from very early stage and terminal stage, RT fits into all categories. If you see, these are the various literature which has been published across all stages using various modalities of RT, starting from hypofractionated, conventional and charged particle. You have, and if you find, there are so many studies, even you have studies including 240 patients, but it is quite surprising why they are not included in the BCLC. And if you look at the local controls in survival, at 3 years and 5 years have been reported across all stages. If you find, it ranges from 81 to 100% at 3 years, and at 5 years it's 69 to 97%. And then even we have the survival figures being reported. So where SBRT fits into the algorithm, if you see, even in the very early stage, where patients are unsuitable for resection or transplant or RFA, there SBRT fits. The evidence, if you see, you have a lot of retrospective. I try to put important prospective studies. This is one STR-SPH study where they have taken tumors up to 5 centimeter and who are not planned for or refused surgery or RFA, and they're given a dose of 40 gray in 5 fractions. And then they have analyzed the local control and overall survival, and they found that the 3-year local control was almost 90% and 3-year overall survival is 78%, with grade 3 toxicities only found in around 4 patients with no grade 5 toxicity reported. So these are the survival curves from that small phase 2 prospective study, and these are the local control rates, and even the intrahepatic failure is also very less in patients who had SBRT. And this is another small phase 2 trial where they have used a 3-fraction schedule, that 45 gray in 3 fractions, and again in this study the median tumor size was 1.3 centimeter, and nearly 80% of the patients had radiologic responses documented according to the RECIST criteria at 6 months. And when you look at the survival, even at 5 years, the survival is around 76.6%, and the local control at 5 years is around 97%. So despite having these data, you don't have RT listed in the algorithm. And thus you can find that SBRT shows excellent results as an ablative treatment in small HCCs with minimal toxicities. So it can be an alternative option in early HCC. And second, in the very early stage and early stage, it can be used even as a bridge to transplant therapy. So the aim for as bridging therapy is, whenever you plan a patient for liver transplantation, until the patient gets the transplantation, then there is risk of tumor progression and death. So bridging therapies are used, which are usually these RFA and TACE. And the evidence for SBRT comes from again this study, where among the patients who have been listed for liver transplantation, nearly 68% underwent bridging therapies. And they found, and nearly 10% received SBRT, and around 1/4 of the patients received TACE, and 60% received RFA as the bridging therapies. And when you look at the dropout rates, it was similar among the all bridging therapies. And then when you look at the survivals, actuarial survivals, irrespective of what bridging therapy have undergone, there is no difference in the survival. And the median dose which was used as in this bridging therapy was around 36 gray. So thus SBRT can be utilized as a bridge to liver transplantation as an alternative to conventional bridging therapies like RFA or the TACE. So next, where SBRT fits, if you see in the intermediate stage, according to BCLC, it is TACE. But still SBRT you can use as a consolidative after TACE, or patients who are unsuitable or refractory to TACE, you can use it. And again you have a number of trials, you have several retrospective and prospective trials, and even we have, and these are the survival rates which are reported with the combined modality. There is a systematic review and meta-analysis of using combined TACE plus RT. When compared to TACE alone, we can find that the survival at 1 to 5 years are significantly better in patients who have received the combined modality, and even tumor responses are also better. But in patients who had received radiation, 3 side effects were important. One is the gastric and duodenal ulcers, ALT elevation, and third is the total bilirubin increase. And this is a retrospective study, again where combined modality has been found to be beneficial when combined to TACE alone in small tumors where they had used a 4-fraction and 8-fraction schedule. And the complete response rates are 96.3% in the combined modality arm. So in patients who have a small HCCs, this combined modality is much better when compared to TACE alone. And as a salvage, that is, you have done TACE and it has failed, there is a refractory to TACE, so you offer SBRT as a salvage treatment. Again, you have a systematic review and meta-analysis
where they took 12 studies involving nearly 757 patients, and they found various range of doses being given, and the 1 year survival is 72 and the 2 year survival is 50%, and the pooled local control rates are around 86.6%. So thus EBRT, you can use it, especially the SBRT, as a feasible and effective local management strategy following incomplete days. And when you offer what should be the time interval between this case and SBRT, 2 studies have addressed that. One is this study where they gave a scheduled gap of 2 weeks between the test and then SBRT, and they found that 70% of the patients had objective response, and grade 3 dysfunction was there only in 2.5% of the patients, accepting the feasibility of 12-week interval. And this study retrospectively analyzed what should optimum cutoff, and they found that the optimum cutoff is around 5 weeks, and based on this they divided the patients into early RT and late RT groups, and found that patients who had early RT, that is within 5 weeks, they have better outcomes. So therefore the optimal timing for administering RT is within 5 weeks, and early administration even as early as 2 weeks is associated with better local control. And next scenario, advanced stage, where sorafenib was the standard, there also SBRT fits, especially in patients having vascular invasion. Here we have a meta-analysis which includes 8 studies and 9 cohorts were included. And among this, if you see, majority of the studies had portal vein thrombosis involved, and they found that the pooled 1 year and 2 year overall survivals were around 53% and 36%. And response rates are even, you have in the range of around 2/3 of the patients having a response. And this is the prospective analysis of the study, and here you find 80% of the patients having at least partial response and with no treatment related toxicities. So again, you have in vascular invasion, you have SBRT as a feasible option. And this is the latest trial which is published in JAMA in 2025 by Lara Dasan. We have a phase 3 randomized trial which compares SBRT versus SBRT plus sorafenib in locally advanced cancer patients who are not suitable or refractory to other therapies, and they found that the median survival after adjusting for stratification factors, there was an improvement in even overall survival, and median progression-free survival, you have approximately 4 months benefit, and nearly 2/3 of the patients in this study had vascular invasion. So next is the terminal stage where best supportive care is advised. There also RT fits. We have again a trial published in Lancet where patients whom they are opted for best supportive care, they had given 8 gray single fraction in one arm, and in the other arm they are not given. Then these are the patients who had painful hepatic pain, and nearly around 35% of the patients, nearly 35% of the patients had hepatocellular carcinoma in this, and they found that combination it helped. So thus summarizing, SBRT is indicated for an unsuitable patients who are unsuitable for resection, RFA and TACE, or who have received these modalities and then they have failed, or who do not want this modality, we can go for SBRT. And as a consolidative treatment after TACE or RFA, if there is evidence of incomplete response following those local regional treatment, as a bridge to transplant. So these are the main indications. And from patient-related point of view, at least a GTV volume of 700 cc is essential, and patients who have a life expectancy of at least 6 months, and childhood. Most of the studies have included patients with from A to B7, and if B8 you can include provided if they are on anticoagulants. And maximum tumor size you can go up to even 10 centimeter, including any associated tumor thrombus. So this is one of our experienced patients who we have treated recently in the 2-3 months back, a cryptogenic CLD case where HCC was present in segment 7. They had underwent TACE. After that, patient had an increase in AFP to around 10,000 with a new lesion seen in the segment 8 as well. And patient was on sorafenib, and we had given SBRT 40 gray in 5 fractions to the PTV, and to the GTV it is 45 and 5, and patient received RT from 27/3/25 to 5/4/2025. And post SBRT almost 1.5 months later in July 25, you can see a significant drop from 10,000 to 1,000, which you don't find with any other modality. So this is the status of SBRT, but we do not know why still it is not included as a treatment option. I think this is a new evolving indication for radiation oncologists. I think many prospective trials, if you conduct, I think definitely we may win in this. Thank you. Currently, immunotherapy is approved in the advanced stage, the atezolizumab and bevacizumab combination. So in the other situations, right now we don't have a level of evidence to offer immunotherapy. So in the advanced stage, only the combination, I think definitely it will help. I think even as a single modality, they have not accepted till now.
Most of people here are practicing, I think, and because immunotherapy.
Actually, trials are going on using combination of immunotherapy and radiotherapy, but we need to have a publication for the to get into clinical practice.
There is a trial which is positive where they have given SBRT and immunotherapy after 2 weeks. This is a T-BEV combination. They found almost 20% increase in the response rate. So they say it's a synergistic effect. We always say radiation is a immunogenic therapy. So this synergism works, and now probably for advanced cases which is inoperable, SBRT followed by immunotherapy is becoming a standard of care.
Thank you, sir. Thank you, sir.
Thank you, sir, for making the session more informative. We invite the chairpersons to honor the speaker. We invite Dr. Krishna Kumar, sir, to felicitate the chairperson.
Proceeding our next academic journey with an engaging debate on hypopharynx, neoadjuvant chemotherapy versus concurrent chemoradiation. To chair the session, we invite Dr. Sarita Damodaran ma'am, Bilrock Hospital, Chennai, and Dr. Ramya ma'am, Stanley Medical College, Chennai, and Dr. Vikas Babu sir, Anviko Hospitals, Kadalur, to chair the session.
I request Dr. Krishna Kumar, judge, to get on the stage, please.
So we are here now for the most interesting session, though the hall is empty. I request all the professors, if you are here, to call your postgraduates to listen to this wonderful debate between the usual contenders, Dr. Madhu Saira and Dr. Anand Selvakumar. So the topic is head and neck, hypopharynx, NECT versus CCRT. I request Dr. R. Madhu Saira from Gem Cancer Center.
Dr. Madhu will speak on NACT. They both are actually friends. Let's see today how it is.
Good evening, everyone. Thanks, organizers, for this opportunity. It is good to see everyone active and energetic, waiting to listen to the debate on whether NACT is required prior to chemoradiation in head and neck cancers. So, as we walk up the stairs, you will be seeing this picture of Napoleon Bonaparte. I am like him today. It is like the loss is probably sure shot in Waterloo, but he still walked into Waterloo, hoping that he will win. That is how I am here today because there is no a direct comparison of NACT CTRT versus CTRT alone in head and neck cancers, especially with hypopharyngeal cancers. But then I still have my arguments in place. If you notice, based on the Globocan data, laryngeal and hypopharyngeal cancers feature among the top 15 cancers, so they are very common cancers. Indian data is the mortality rates and incidence of hypopharyngeal cancers is very common, especially among females. And you can also see that laryngeal cancers features as the third most common head and neck cancer in men. But the most dismal point is that the smallest or the lowest survival of head and neck cancers with chemoradiation is with hypopharyngeal cancers. As you can see that the last 4 in the box are actually pharynx unspecified, hypopharynx and then larynx. So the least amount of survival is here because of the complexity of location, because of the advanced nature of its presentation. And you can notice that based on the population based registry data in India, it is only 25% survival rate for a hypopharyngeal cancer with chemoradiation. So don't you think we have a scope for improvement, and shouldn't we push the bars above? So what are the points which we'll have to argue for giving NACTs to how to improve local control, how to improve survival, and most important of all for radiation oncologists is how to preserve the organ, and that is laryngeal preservation. So these are the trials that have been done in using NACT in from 1990 to 2017. As you can see, so many trials have been done, and the premise is laryngeal preservation. That is what these trials have all done with. And if you see, starting from 1990, when radiation was possibly pitched as an alternate to surgery, people have been giving neoadjuvant chemotherapy in practically every single trial that has run. Initially, they started off with cisplatin 5FU, and they also added docetaxel and the triplet regime actually made a very big difference in the NACT scene. So no trial has actually been run without NACT being the component of its one of the arms. Well, let us start off with one of the oldest trials, that is the Italian trial. It was designed again to compare PF, that is cis5FU versus TPF, and the results are like this. The complete response rates are much higher, that is it is 33% with the 3 chemo regimen versus 2 chemo regimen followed by chemoradiation. So if you were to add taxane as a molecule, then the response rates are going to be higher. What do we want as radiation oncologists? We want to improve local control. So in addition to chemoradiation, adding a TPF will actually improve local control. Coming on to why CCRT alone is so inadequate, you can notice that the McKenzie trial, which is one of the largest trials that has published concurrent chemoradiation in head and neck cancers, the benefit of adding concurrent chemotherapy to hypopharyngeal cancers, the benefit is least for laryngeal and hypopharyngeal cancers, whereas for oropharyngeal and other oral cavity cancers, the difference is different, whereas it's only 4% advantage if you add chemotherapy to hypopharyngeal cancers. In these cancers, most of the times people have already given neoadjuvant chemotherapy. So just giving radiation alone is enough rather than adding CCRT if you have given NACT. That is the inference from McKenzie. Well, then came these 2 big trials, the TAX 323 and 324, which from our resident days we have always been quoting for NACT. But Europe and American protocols both were very good, reasonably tolerated, and we should notice that with 323 and 324 there is approximately anywhere between 27 to 30% of cancer death risk reduction using the triple regimen. So if that is going to be the case, why not use TPF ahead of CTRT is the biggest answer. These trials unfortunately compared only again with cis5FU and TPF, not with CTRT, but we have the answer and the message here that if you are going to add taxane, that is the third chemo drug, then the risk reduction is much higher. Then there are 2 trials which I am sure my opponent will quote as negative trials, one being the DECIDE trial. Let me bring out the positive point of the DECIDE trial. Unfortunately, the trial was closed ahead of its accrual because of various factors, and then because TPF was the standard of care at that time and they did not pursue this trial, in spite of early closure, there was a trend towards better survival with TPF chemotherapy followed by chemoradiation in the DECIDE trial. You will also notice that a very important endpoint, cumulative incidence of distant failure is significantly lesser in patients who would receive TPFS chemotherapy. Coming on to Paradigm trial, which again is a trial that got terminated early, you will notice that the conclusion is very, very clear. We cannot rule out the possibility that there is a difference in survival. That is because the trial got closed early. So if there was an opportunity, you should probably give NACT and then give CTRT. That is the conclusion of this randomized trial. Well, do we have some Indian data at all? Yes, this is a randomized trial done in Rohtak, India. And then this data actually again says people who received NACT versus those who received alternative regimens or hypofractionated regimens, the response rates were nearly 100% with those who received NACT. So this is a small but an Indian trial. Coming on to HPV incidence, again we know from oropharyngeal cancer data that using NACT improves survival in oropharyngeal cancers. 18% of hypopharyngeal cancers are HPV positive. So let us work the math. NACT will definitely be beneficial. Well, on this slide showing the patterns of relapse, you notice that the distant metastasis rates is highest with hypopharyngeal cancers. Now go back to DECIDE, it does prevent distant failure rates. So hypopharyngeal cancer where the failure rates are higher, you better use NACT. Well, coming on to the most important aspect that the radiation oncologists have been fighting for the last 50 years is the organ preservation, and these are all the trials that we know for sure that they are all positive trials, and you can notice that the laryngeal preservation rates are at 60% at 5 years if you were to use induction chemotherapy, and this EORTC trial gave us the answer. If you are going to use a triplet regimen, the preservation rates are significantly higher over the years. Well, coming on to a survey that the AIMS people have done, you should notice that 150 oncologists have responded, and there is, though there is no evidence, at least 78% of them are actually practicing neoadjuvant chemotherapy in head neck, and that is the answer. So verdict does not have to come from the judge, it's already come from the survey. I did a small survey of all the faculty here, and I received 19 responses. The preferred treatment for hypopharyngeal cancers is definitely CTRT, 94%. Do you believe in NACTRT? People, you have answered this. At least 63% do believe in NACT in head neck. Where do you use it? In N2s and N3s? Yes, possibly, and in large primaries. So what does NACT help with? It helps debulk the disease, reduce the burden, etc. So the answer from the audience survey again is that we will be using NACT. So I conclude saying NACT does have a minimal improvement in local control, trend towards survival, and then reducing distant metastasis. And finally, organ preservation is the key for any radon, and that is what is achieved by NACT. Thank you.
Thank you, Madhu. And he has left a few things open for Anand to come discuss about concurrent chemotherapy.
Thanks to the organizers as well as the AROI team for having me here. So I'll be talking in favor of chemoradiation is the standard of care in locally advanced hypopharyngeal cancer. Do you remember the scene from Titanic? There are many memorable scenes in Titanic. This is one among them. When the entire ship is sinking behind, this man will be playing violin till the ship sinks. Could you see me behind? So that is me running behind with a lifeboat to save the people. So the good thing is, Sai also plays violin during his free time. I noticed this in one of his Facebook posts. So why we started trying induction chemo in hypopharyngeal cancer? Induction chemo came with promises like it can downstage the tumor, there will be better organ preservation and early control of micrometastasis, and it can it will help you to select the patient for organ preservation, and there should not be any added toxicity. That's what we expected earlier, and there should be some survival benefit. But what happened, this is the Paradigm trial, although this trial got closed earlier, we have some data on that. There is no PFS benefit, there is no OS benefit, leave that. But if you are seeing the toxicity profile, you could see the febrile neutropenia, it got doubled when we are introducing induction chemo, as well as the neuropathy rates are very higher, as well as the mucositis rate was also very high. This trial compared the TPF concurrent chemoradiation versus chemoradiation alone. If you are seeing the overall survival, it's 62 months versus 63 months. And induction chemo didn't improve the outcome even in the responders in this trial. This is the DECIDE trial. This is one another American trial. There is no difference in the DFS as well as the PFS as well as the overall survival. They compared TPS followed by concurrent chemoradiation versus chemoradiation alone. There is no overall survival benefit. If you are seeing the SCI rates, it's almost double with the induction chemo arm, and there were 4 treatment-related deaths in the induction chemo arm. This is the meta-analysis we know from the head and neck group. So all timing of chemotherapy, the benefit is like 4.5% in 5 years. Like if you are giving chemotherapy for any patient, either it's induction or adjuvant or concurrent, the benefit is 4.5%. If you are giving for adjuvant alone, the benefit is not that significant. If you are comparing with the induction and concomitant chemotherapy, the benefit is more for the concurrent chemotherapy arm, like it's about 6.5% versus 2.5%. So this is the long-term outcomes from the Spanish trial. Again, the TPF followed by concurrent chemoradiation arm, they didn't show any benefit in the PFS as well as the overall survival. There is only less than 50% of the people completed all 3 cycles of IC, the induction chemo, versus about more than 80% received the concurrent chemoradiation. That is the mainstay of the treatment. This is one another trial from French group. Again, there is no benefit in the OS and PFS. They compared between TPF. This time they have tried cetuximab also for these patients. They replaced the cisplatin with cetuximab. There was more organ preservation in the responders, but there is no overall survival in that responders also. And the non-responders fared very worse. Like the 3-year overall survival, the difference is between 60% versus less than 30%. This is one another Italian trial. They have compared with they have added cetuximab also in this trial. This is the only trial I came across which had shown some overall survival. But the thing is, they have included more than 50% of oropharyngeal cancer, and we know well that these oropharyngeal cancers will be doing well, for any kind of treatment that we give. So when we see a lot of negative trials and suddenly one trial is showing benefit, means if multiple trials fail and one shows marginal benefit, means it should be scrutinized then celebrated. So I went through the toxicity and death rates. Like the neutropenia rates were very high in the IC arm, like it's up to 30%, and there were treatment related deaths that went up to 7%. Are we ready to accept the 7% death in the IC arm? So they try to prove that TPF is the standard of care in the TAX 3-3 study as well as TAX 3-4, but there is no standard chemoradiation arm in both these trials. Like 3-3 has no chemoradiation arm; it tried only with radiation, and 3-4 compared with the carboplatin and radiation, which is not the standard of care. In that thing, no chemoradiation arm was there to compare. The neutropenia rates were very high. It's up to 85%, and not suitable for unfit patients because they included only ECOG of 0 and 1, but VC patients more than 2. It requires intensive supportive care and more care. There were more chemoradiation dropouts and delays, and then we have to take care of the cost and complexity of the IC. If you are asking me whether the TPF shrinks the tumor, yes, but it also shrinks the patient and the bank balance as well as further treatment options. We have to admit the patient if they have to receive TPF. They have to admit for 5 days. And we have to put a central line, there will be toxicity, and most of the time we see patients with poor performance status, there will be dropouts and there will be delays, and we have to take care of the cost also. Because the head and neck cancer is not a chemo-curable disease. The chemoradiation is going to be the mainstay of the treatment. If you are seeing the dropout rates, it's like nearly 10 to 30% of the people didn't go for chemoradiation at all. There will be dropouts more if you are introducing induction chemo. So why we stopped trying IC? Although it came with promises, there was some tumor downstaging, but it didn't translate to overall survival. For that bulky disease, we can try adaptive radiotherapy. That is one another option for those patients. And we expected better organ preservation, but it happened only in responders, and it's only a delay for the non-responders. And we thought like we will be getting early control of micrometastasis, but we couldn't see that difference in the most of the trials. And we thought like it will give you some idea about patient selection, but it didn't happen because you don't have predictive reliability for these patients, and there is no survival benefit. So giving IC is as a general strategy to manage waiting list is substandard. I know some of the high volume centers, they are using induction chemo when there is a high waiting list for radiation. If you are asking me, induction chemo is very good to manage the waiting list, but not the patient. So how many of you, I don't know, are using the iPhone? So we will be getting pop-ups like there is an update for your iPhone. So whenever you are doing some update, you will be expecting some kind of boost up in the performance. But finally it ends up with some battery drainage, like it starts draining more in the subsequent days. So you will be buying a new phone in the near future. So people thought like the 5 days of IFU is very toxic, so they started comparing with the 3 days of IFU, or they replaced the cisplatin with carboplatin or cetuximab. They try to avoid 5FU itself by giving carboplatin and paclitaxel. Still they see some toxicity. So whatever the TPS pizza is more like a burnt pizza. If you are reheating that pizza again and again, you won't get a good taste of that pizza. You have to go for a new base, you have to go for a new ingredient, then only you will get a new pizza. So the integration of immunotherapy is going to be in the future. We have already some results from the keynote. So the IC could be prime the tumor microenvironment for immuno. So probably in the near future we will be giving pembro as a part of induction chemo. And probably the functional imaging and adaptive radiotherapy will give you more chance to escalate your dose. So currently we are not doing that. Probably it will give you some space for dose escalation in head and neck cancer, because the locoregional recurrence is more common in head and neck cancer. And in the near future we will be doing more biomarkers and radiomics to select the patient than that of taking all the patient for TPF. Like the radiomic signature, genomic risk factors, and currently most of the trials are taking HPV positive patients also. We know well that this patient don't need such kind of intensive chemotherapy. We are doing de-escalation for this kind of patients actually. And HPV can also possible in hypopharyngeal cancer, like the literature says, like the incidence is about 15 to 20%. So yeah, this is the open poll for all the audience here. When your kitchen is on fire, how will you save the house? I will be giving you two options. Will you order for a fire extinguisher on Amazon, or will grab a bucket from the bucket full of water from the bathroom to save your kitchen? What will you choose?
Pick the bucket. Pick the bucket.
So that's it.
Thank you.
I think, yeah, he did bring out the points. So we don't have a head-on comparison. So reducing toxicity can be done using gentler chemotherapy. Probably, from the lessons that we've learned from interlace and cervix, we can probably think of some lesser or less intense regimens like carboplatin. Adding immunotherapy could be one of the ways of combating. But then definitely there is a role for improving local control by giving NACT in head and neck cancers, especially hypopharyngeal cancers, and I still would vote for NACT in a much gentler way for hypopharyngeal cancers. Thank you.
Let me add a little bit more points. Talking about hypopharynx, I think we all know it's a bad disease to treat compared to any other subsets which we have. And also we do see a lot of poor responders among the women in this group. So what we need to identify is more, I think NACT will be more useful in places where we are looking at patients who are radio resistant. So that is one area where we need to identify and then find out where the radio resistance is much higher, that patients can be treated. Of course, M3, as Madhu had already put it in the survey, M3 is one place I think we need to look at neoadjuvant chemotherapy. And other than somewhere even N1 or N2, even less than 3 centimeters, we don't see a complete response in many of these patients. So those patients will definitely be useful with NACT, reduce the bulk, and probably then go in for concurrent chemo-RT. Otherwise, what happens is we give a concurrent chemo-RT, we have a lot of residue. In the primary, it is going to be difficult. If it is in the node, then I think still we can do with the make this section. So some intrinsic factors which are there, which has to be identified, probably some DNA damage response enhanced or DNA repair which is upregulated. So these kind of things, unless it comes into work sooner or later, then I think NACT will be having a much better picture. As they said, there is no direct comparison between both. In our clinical practice, I think it may be useful in places where we sometimes our gut feeling says this patient is not going to respond with CTRT and we need to go for NACT 3 cycles and then proceed with chemo. That's it from my side. Anybody else want to contribute anything? Yes.
Age of the patient definitely is one very important criteria. When we are going for very high doses of chemotherapy, sometimes they are not able to tolerate. So we really need to be very careful when we choose the patient. The disease, how big is the disease? Invariably when I say aged patient, the disease is also large. So sometimes we are very tempted to give some chemotherapy, but then we need to be very cautious.
Thank you. Both of them did a very wonderful job. Thank you.
Thank you, debaters. That was a worthwhile debate. Now we invite the chairpersons to honor the speaker and the judges. We also invite Dr. V. Srinivasan sir to facilitate the chairperson.
Thank you, sir. Thank you, ma'am. We are ready to dive into the next presentation on the evolving role of artificial intelligence in smart radiation. We welcome Dr. Deepika, MGM Cancer Institute, Chennai, Dr. Gautam Vaidya, Cancer Institute, Alayar, as chairpersons for the event.
I thank the organization for this opportunity to organize this forum today. I was talking about artificial intelligence. At some point of time, I will probably expect one of you to define what natural intelligence is also. Let us start. So I request you to look at this slide and I want you to find the answer for that last thing. It will give you a clue about how computers work. So have you had a look at it? I'll just move past. So this presentation, this is how I am going to address it. The overview of what AI is, then specifically what AI in radiation oncology entails today, then how it impacts patients, how it impacts radiation oncology. So the forum, I am assuming this forum I am going to assume as being a beginners and that is the level of discussion here. So what do we mean by natural intelligence? We keep talking about artificial intelligence. Have you ever thought about, can you answer this? The input is 2 and 3, the output is 7. 50? 49. Right, so what you saw is, you saw 2 data points and you saw a result. The third data point, you are immediately able to figure out the pattern and act upon the pattern. This is what natural intelligence is. The same thing I have done in the next slide. If you have some time, you will figure out. This is a little bit more complicated. But if you look at it and think for 2 minutes, you will figure out what the pattern is. So this is what natural intelligence is. For the sake of this presentation, I will try to define natural intelligence as this. Number 1 is finding patterns. Number 2 is understanding the significance of the patterns. It is not just sufficient to find the patterns, you have to understand how it matters. And next comes the human urge to act upon it or adapt to it. And the final thing, what we are raving so much about this large language models, one person has identified a pattern and figured out the significance, the ability to communicate it to another human being by using language. That is the pinnacle of intelligence. That is why anything that speaks in language, we have an immediate urge to think it is intelligent, but it may not be so. So just like we have this PTVCTV, we have a concentric circle here. It will be there in your school students' book henceforth. Just remember it as AMD. Artificial intelligence is the outer ring. Inside you have machine learning. Deeper you have deep learning, which will have neural networks. Just for the sake of nomenclature. Now, in artificial intelligence, what we are trying to do is we are trying to imitate human behavior. That much is clear. But when you see humans, you can encounter two different types of humans. On the one side, you have a scientist or a researcher. On the other side, you have a school kid. So what does artificial intelligence tries to imitate? Any idea? What is the original idea when AI was developed? Were they trying to imitate the school kid or they were trying to imitate the researcher? Any guesses? The original AI was developed to imitate what specialist was trying to do. That is what the original intention was. That is called narrow AI. Whereas trying to imitate what even a common person can do, that is called general AI. Surprisingly, narrow AI is what is evolved, what is present, what is making impact now. General AI is nowhere near existence as of today. But there are two different schools of thought. Some people say it is going to come soon, some people say it will never come. So this narrow AI is what is important in oncology today. This is what we are talking about when we say AI in radiation. Right. Look at this slide and these words. These are the different components of what we employ when we deal with the patient. Either we use some part of knowledge, or we use some skill, or we use some intelligence using the data and figure out the decision. So why these three things matter, you will understand in 3 slides. Knowledge, as you all know, it can be stored in computers. No human can match a computer in terms of ability to store knowledge. Skill, again, we think humans are good at it, but eventually any machine can be taught the skill that humans are trained to do. But intelligence, so far machines cannot even come close to what a human being can do. Because just now 5 minutes back we saw 2 slides, 2 inputs, the third input immediately a human being was able to figure out. If I had given that problem to a computer, no matter what, how much time it takes, it will not figure out that answer from the 2 data points. That is the bottleneck for a computer. So, this is what we do with the patient when we see them in the OPD. Every single point, every radiation oncologist will be doing in their routine interaction with the patient. So, this is the one important slide. There is one more slide where AI plays a role as of today in radiation oncology. Of all these different steps that are involved in patient care, AI has a role right now in contour delineation. It has a role in dose prescription and plan evaluation, and obviously as a combination of this in adaptive RT. This one slide, if you understand, this is the role of AI in RT as of today. Now, we all know what this slide entails. So when we first learned in physiology that the right eye has 2 halves of the vision, one goes to the left side, one goes to the right side. I think these days the school kids are learning, but when we learned in our first year physiology, it was like magic for us. That there is a nasal depreciation of fibers and 1/2 of the world goes to one side of the brain. So this actual paper was published in 1874 and somebody did methodically, they did neurophysiology experiments and figured out this and understood this nasal depreciation. When it was published initially, it must have been hailed as an intelligent work of a brilliant human mind in 1874. In 2025, it has become plain and simple knowledge in that the first year MBBS students can reproduce. So you remember initially I showed a slide, knowledge, skill and intelligence. This is the interaction between the intelligence and the knowledge that AI is able to do. Knowledge requires data and memory. Intelligence requires data and analysis, critical thinking. What AI does is, it takes the work of lot of brilliant individuals whose analysis has been collated and converts this intelligence into a memory. Once it becomes memory, it becomes easily retrievable, easily implementable. So the source of intelligence is only human being. That AI converts into a knowledge. We know that knowledge can be stored in a computer and it can be retrieved easily. So this is what's happening in AI. Now we will forget about. Let us come to AI in radiation oncology per se. So as we see, these tasks in the workflow of planning, 2 years back, if I have asked you, among these tasks, what is the common factor that are specific to these things? One is image segmentation, you do a dose prescription, you do a planning, and then you do a quality assurance. These are parts of the workflow. Can you tell what is common to them? Can you think of some parameter, some aspect which is common to all these activities? One is, it takes time to prescribe, to see the plans, evaluate the plans, and then do quality assurance. It takes time, number one. Number two, there is a definite inter-observer variability. One person is doing a contouring, the other person is doing a contouring, definitely it is not going to match no matter the same guidelines they are following. This is a fact that happens every day, and that is why even papers are published asking for inter-observer variability in contours. So that much is the prevalence of this thing. But this is what we do every day for every patient. Imagine, like suppose a fever patient is coming, suppose the prescribed dose is 500 milligram. Let us say one consultant is prescribing 450 milligram, another consultant is prescribing 600 milligram. Will we be accepting that? The therapeutic part, there is inter-observable variability. We will not accept that in a pharmaceutical scenario. But in a radiation scenario, it is a fact of life that there is inter-observable variability. So, in image segmentation, there are AI models that are coming up. There are different vendors, different institutions that come up with solutions. And recently, we must have listened to one Tata Memorial Center. They came up with an auto contouring machine learning trained model. So, what we should remember is, even if there is an auto contouring, we all know this, still there needs to be a human validation. There are two reasons for this. One is clinical reason, obviously. Whatever the vendor gives, we cannot assume that it is correct. There is bound to be some variation, some flaws which have been overlooked that we only will be able to judge and point out. So that is the clinical reason. Obviously the legal reason, there is no legal framework which you can blame, where you can blame the AI vendor for a wrongly delivered plan to a wrongly contoured volume. That is not possible. So no matter what AI is there, there has to be human oversight. That is the fact of life. Now, typically what will happen in a contouring station, in a teaching institution or even in a private sector, it will be contouring and it will be approved by the consultant. Suppose for let us say a site like cervix or endometrium, the result will take probably 20 minutes and the consultant will then go on to approve. If you incorporate automatic segmentation in that can probably finish the contour in 3 minutes or 5 minutes. So what took 20 minutes now takes only 5 minutes. So what is the impact of this? So here in auto segmentation, what AI does is it does not do anything different from what a human being will do. It does the same things, but it does with more consistency across days, across space. Any institution it will produce the same contour, any day it will produce the same contour, which cannot be assured with humans. So that is what AI delivers. It delivers speed, it delivers consistency. And incidentally, if you have a AI, you don't need a junior manpower, resident sitting in the console and contouring all the things, because that will be done by the AI. And it allows probably the junior manpower to be involved more in patient care and research. Now, image segmentation, when we say AI, we automatically have an intuitive understanding of how it helps. But when it comes to radiation planning, it is not so intuitive, so I will take some time to go through this process. So first in planning, IMRT planning, what you do is, you mark the geometry, you mark the volumes, you mark the OARs. Then you prescribe the dose, that is, you give your expectations to the system. This much dose I want to this much area, and it is a matrix. It is not one number that we are trying to achieve. We are giving a matrix of values and asking the system to achieve it, and it generates a plan. And most of the time, do you think the first plan it will be happy to your expectations? It is unlikely to be. So the expectations will not be met. If that is the case, what will you change? You have given a volume, you have given expectation, and that expectations are not met. In IMRT, what can you change? What should you change? You cannot change the volume. That is the disease. That is a normal anatomy. What you can change is only the expectations. That is what the iteration is. So in IMRT planning, the volume is fixed, whereas the expectation is subject to iteration. That is what the IMRT plan involves. So this iteration is what happens in the TPS between you and your physicist. Suppose a difficult base hospital planning, GBM planning, you have very tight constraints close to the critical structures. The first plan, it will not be possible. So it will go on again and again. Probably we will know, like we will be breaking our head to deliver, especially for the boost phase, the precise dose without compromising the OARs. That will be the challenge that you are facing. So the first expectation, when I say the first expectation, the default dose prescription that you are giving a matrix, and then that matrix is not achievable. In OPD, in TPS, what we do is, this flow we will do for most of the patients, if not for every patient, for simple patients. So if this takes for a fresh radiation oncologist, for an inexperienced radiation oncologist, or for a radiation oncologist new to that particular site, this process can easily take around 40 minutes, or it can even take 2 hours depending upon the complexity of the geography, anatomy. Whereas once you start planning, you will understand intuitively for these areas, these high expectations cannot be given, it will not be deliverable. So what we will do is, we will scale our prescription accordingly, we will lower our expectations accordingly, and that will be the time taken. Probably what took 40 minutes will be over in 10 minutes with the experienced radiation oncologist. Now here comes the catch. You take thousands of radiation oncologists who have produced thousands of brilliant plans which deliver doses accordingly for complex sites and feed it into the artificial intelligence system. Now what it will do is, you give the geometry and you give the trained AI model this geometry. What it will do is, it will straight away give the prescriptions which are likely to be delivered rather than which are likely to be ideal. So that is what the AI system does. So it reduces the iterations, it reduces the planning time. So it behaves like a senior radiation oncologist. It will not start from expectation 1, it will go straight to expectation 4 or 5 and finish out the planning. And it does not involve us taxing our brains to figure out how to fix this dose matrix.
It has acquired natural intelligence.
Acquired intelligence. That's it. So in the workflow, what artificial intelligence does is, it cuts these iterations. Imagine for a complex case what it involves. You will probably get the plan ready in 5 minutes or 10 minutes without breaking your brain. So for a new planning patient, this auto segmentation, if you apply artificial intelligence to both the auto segmentation and the radiation planning, what happens is, it makes things faster, it makes things more consistent. Now come to adaptive radiation. In adaptive radiation, what we are faced with, the anatomy has changed on that particular day, so we have to recontour and probably recheck the dosimetry again, and if needed, if there is significant shift, we may have to replan also. So in a new planning, what we have the luxury of having 3 or 4 days to contour and plan. In adaptive RT, we have the constraint of doing all those things within 15 to 20 minutes. Who is good at this? Only the AI systems. This auto segmentation and radiation planning are mandatory when you are going to implement AI. So it makes things faster. It makes possible. Otherwise, if you are sitting in the treatment console, per day you have 5 patients who are requiring auto segmentation. Probably the first 2 patients will be happy to do that. The 3rd and 4th patient will probably be mentally taxing. You may not do that. When you have an AI system for that, it makes adaptive radiation more possible for every patient. It just not makes it faster, it makes it possible also. So that's what adaptive RT. How it impacts patients, this implementation of systems. Number one is reduce observer variability. So obviously that translates into patient quality. So any patient will likely to have the same consistent contouring when they enter the TPS. And technically we can say faster treatment start times. If you are simulating 5 or 10 patients per day in setups like that, these will allow you to start the treatment faster rather than asking the patient to wait after the simulation is done. That is one advantage. And for patients where adaptive RT will help, this will enable lower the threshold for the consultant to make it feasible. Otherwise they may not even consider it because of the logistics involved. Whereas AI will make it feasible and more patients can likely to benefit from adaptive RT. So this is how it impacts the patients. How it impacts the radons. Lesser time looking at the screens. We are not going to spend hours with mouse contouring stuff. Lesser workflow for junior manpower obviously. And we can approve more plans, or we can approve more replans every day, which translates into better patient outcomes. But we have additional burden of assessing these AI libraries, AI vendors, because once there is money in it, there is likely to be a number of vendors who are coming up with solutions, and we are the ones responsible for the patient outcome. So we have to decide which of these libraries, which of these vendors are more likely to benefit the patient, discuss the pros and cons, and then decide on the clinical validity of these models. This will be additional work for us. Now, in 2025, suppose a new vendor is coming up with a commercial model. They cannot sell it to doctors. They have to sell it to hospitals. Right now, probably what it happens, this applies not just for radiation oncology, for any AI solution in healthcare. They will go to the hospitals, and right now the hospitals are taking an opinion from the doctors whether to go with it or not, and then the purchase decision is made. This is the scenario now. In 2030, let us say in 5 years from now, this may not be the case, because you see the explosion of AI that is happening, the gain of trust that is happening with AI. The vendors will go straight to hospitals, the doctors will be cut out of the loop in their decision making whether to purchase it and implement it, and we will be forced to react. That is likely to be the scenario in the future. And as more and more money are put into AI systems, how are the hospitals going to take it from? They have to either pass on the charge to the patients, which is, it's a business decision, I'm not able to comment on that, or they can take out the money that they are paying to the doctors, especially the junior doctors. So that will be the economics of it probably. So right now, for a hospital, if you have a senior consultant and a junior consultant, the value perceived is lower for the junior consultant, and the senior consultant will have a more value that is perceived. But once AI is implemented into healthcare systems, in patient care systems, what is likely to happen is this. The AI named junior doctor will be the one with the lowermost value, whereas a AI named senior doctor and a AI aware junior doctor are likely to be kept in the close bracket, similar bracket of similar value, whereas a AI aware senior doctor will be of immense value to the organization. This is how the future is likely to be. Finally, a word about pitfalls of AI. This is a little technical point. So what you have to understand is, as I said, narrower the domain, more efficient the AI model is. So if you have a workflow which has 10 different consequent steps, if one guy is coming and saying, I have an AI model which takes care of all the 10 steps, and another guy is coming and saying, I have a model for only the 4 steps, and another guy is saying, I have a model for only 6 steps. So what you should always choose is, choose the model which has the narrower expertise, because anybody who claims bigger expertise, they are likely to have lower precision. Why? Because if you take, there is a compounding of error in a multi-step process. So if the one step is having 95% accuracy, you do it without basically one step, there is a model output is there, no human being is overseeing it. You feed the output into the second step of the model without human oversight. What will happen is that error will keep on compounding. So what happens is 95% in the first step will translate into probably 30% or 40% at the end of it if there is no man in the middle. So the key is to have a man in the middle wherever you are having an AI system. If you see open and type ChatGPT or Google Gemini, the last line will be AI is likely to make mistakes. Please verify. That is what they say. When it comes to patient care, there is no scope for even 5% mistake. So any model, AI model, should have a man in the middle at every step of its flow. And black box algorithm is a theoretical concern where the output will look like convincing, but there may not be any logic to it because we cannot have access to the internal logic of the model. That's it. Pre-AI, we are living in a slower world. Post-AI is a busy world, but it is faster. So that speed gives us. It is not like a car is allowing us to go to a place faster. Because we have a car, we can choose to go to places which are much farther. It opens up newer opportunities, but also there are dangers are inbuilt. But what is for sure is there is no going back. We have to adapt to it. Thank you.
Thank you, sir. It was a very clear-cut presentation. Most trending AI made it very simple. So, take-home message would be we have to be very much thinking about the dose accuracy, prescription accuracy, and time consumption mainly. Though with IMRT and BMAT, we can have a lot of multiple generation of plans, but still we have to approve. Yeah, we have to approve. Definitely, humanized approval is mandatory.
Thank you.
So one question from my here. So all those data were from the era of generative AI. Now we have moved on to the era of where AI acts as an agent, and there have been a lot of data which is published where the AI does the reads all the protocols and makes a decision, and another set we have all the experts given decision. And so far we have not even had the 5% deficit in the accuracy. So how do you see that, sir?
Accuracy, you are saying the AI is accurate.
That's what the published data
right.
says.
I think Dr. AS case here, just for fun, I made a presentation about AI in Meenakshi. In live, I took down ChatGPT saying, ChatGPT, please give me a Tirukkural about breakup. This is what I asked it. It gave me a Tirukkural. It had a number also. The next window, I opened the actual Tirukkural, that number, there is some other Tirukkural. It came up with a confabulated version. So it takes 2 minutes to take down ChatGPT, so don't worry about the accuracy of ChatGPT.
Every one of this has a man behind it who has conceived this and brought it out.
Exactly.
90% of this AI work is done by non-medical people, engineers sitting in rooms sitting there. Unless these are validated by doctors, I think this is a dangerous game. We have to play it very safely. I know I may be one of the senior with AI naive, doesn't matter, but still I have worked in all these AI, I have developed software in nuclear medicine and in radiation oncology, planning systems with a very renowned company who gives you only half-baked data.
Exactly.
They don't give you the entire data. I propose that we use our own Indian data, which refused.
Absolutely.
And so please take it with a pinch of salt. None of this AI, these are all marketing gimmicks. The best one is acquired intelligence. Please acquire intelligence by coming and attending the conferences and being here. Thank you.
I just would like to conclude. When AI came, they all said it will be a threat to radiation oncologists and there will be loss of job. You will not have job. I am telling you, you have made it very clear that AI is not going to replace radiation oncologists. Thank you. Nice talk.
Thank you.
We should also encourage AI labs like how they do in TMH. We should also do that, and we have to go in depth to know the reality.
One area where AI probably helps, I confine myself to radiation oncology, but when it comes to oncology, AI can find patterns which are more intricate than what human being, like let us say staging. We have 4 stages for any cancer, which is a pattern. Stage 3 has a poorer prognosis, stage 1 has a better prognosis. This is a simple pattern matching. But AI can probably predict more deeper patterns, which can generate hypotheses, which can be validated by oncologists. So that will be one exciting area.
But they are already there, and the people come with those things and show it to us and ask what is the management.
Yeah.
The management also is given by us. So these are happening already.
Yes, sir, very true.
That is the dangerous game which is happening.
Very true.
The 2025, 2030 comes in. 2025 நடக்குது corporate hospital. They don't discuss. Management decides what they want to buy and it comes to us. They don't discuss with doctors.
Thank you, sir.
Thank you, sir.
Nice talk. So actually we are, I think morning I had shown our lab, the AI lab. So we have a supercomputer, Param. So we are actually cutting down, we are working on auto segmentation, one of the projects. So what a resident takes 5 hours, I'm sorry, none of our residents can do in 20 minutes. So what residents take 3 hours, 4 hours, we are able to do in 2 minutes using that. So I think we need to have inbuilt in-house solutions, because I think the commercial vendors, there are a lot of problems, and I think it's very expensive. I have seen those when we go for conferences. So I think in-house solutions are best, and I think once we are ready, probably we'll share our expertise. Thank you.
Thank you, sir, for the brainstorming session. I invite the chairpersons to honor the speaker. We also invite Dr. Gandhimati, medical oncologist, Thuthukudi Medical College and Hospital, to felicitate the chairperson. Turn the page to the last session of the day, panel discussion on the endometrial cancer. We welcome Dr. Anita Kumari. We welcome Dr. Anita Kumari, Tanjavur Medical College and Hospital, Tanjavur, and Dr. Selva Lakshmi, Chengalpadu Medical College, to chair the session.
Dr. S. Gandhimati, medical oncologist, common medical college hospital.
So this will be the last session before GBM. I will try to make it quick. So for radiation oncologists like us, endometrial cancer, it should be just like any other adjuvant radiation therapy after surgery. But but this ever-changing FIGO system, ever-increasing complexities of the prognostic risk groups will make it really a head-scratcher. What options we need to choose, whether it is observation, whether it is vaginal brachytherapy, whether it is external radiation, or EBRT followed by VBT boost, or chemoradiation. But if you look at the positively, if it is like that, usually we will have only one stick, like adjuvant RT, and you treat every patient with the same stick. But here, our showcase is full with options. So we can choose the correct option to the correct patient. And another side effect of this is our tumor boards have made much entertaining and spicy. So maybe this is one such intricate decisions making. Maybe we can make like some AI models might work, because when you have a much complicated scenarios. So we will, like Alara, we will try to make it as simple as possible. And first we will start with this early stage. So this is like a typical early stage 68-year-old. Surgical staging has been done and tumor maximum size is 5 centimeters. I think it is more than 50% of the myometrium is involved and it is grade 2. So it is basically 1B, 1B grade 2, and don't ask now this molecular factors because this is flashback, pre-molecular testing era, like our old 1B grade 2. So what will be the further plan of management? No LVSA. No LVSA, no lymph nodes, just 1B, more than 50% grade 2.
It's a 1B grade 2.
Yes.
So basically intermediate risk.
Intermediate risk.
So since the age of the patient is more than 60 years, vaginal brachytherapy is preferred.
Vaginal brachytherapy. Yes.
Vaginal brachytherapy.
So I think the panelists are unanimous in their decision. It is standard intermediate risk. So vaginal brachytherapy. So usually we will have, like for any cancers, high risk, low risk is there, and for endometrial cancer you have intermediate risk is there, and to complicate the situation you have a low intermediate risk and a high intermediate risk. So for the, just to revise it, how this high intermediate risk comes is, it is from these two RCTs like POTEC 1 and GOG 90. Both explored whether we have to observe the patient or whether we have to give pelvic RT. But here is the catch. Both of them did an unplanned subset analysis and they found out that only in this high intermediate risk group, this subset, only the adjuvant RT is high enough to decrease the relapse rate. So these are the two high risk. POTEC 1 has got its own high risk, high intermediate risk. GOG has got their own high intermediate risk. So this will typically comes under the POTEC 1 because more than 60 years, as Anbarsi correctly told, it is more than 60 years. Two risk factors are there. More than 50% myometrial is involvement. So we have to consider adjuvant RT. So different institutions will follow different. Some will take POTEC high risk criteria. Some will follow the GOG high risk criteria. So which one to find out? But both of them didn't reach a consensus, and there is no consensus. Now contouring, we have consensus contouring guidelines, but for here there is no consensus high risk intermediate group, high intermediate risk group. Okay, so now the next question is,
If it
fine, fine. This is pre-molecular testing around. So right now, so the POTEC 1 went ahead with POTEC 2, POTEC group, that whether VBT or external beam radiation therapy, and it comes out that vaginal brachytherapy achieves excellent vaginal control similar to EBRT. So hence EBRT remains the standard of care. We will revisit this a little bit later. So as of now, okay, vaginal brachytherapy can be given. Now the third question is length of the vagina. How will you treat? Upper third, upper half, upper 2/3, or entire vagina? I know different institutions follow different protocols. Upper 2/3.
Upper 30, so it's upper 30.
4 centimeters. So definitely the consensus is not the entire vagina need not be treated. That is the consensus. So if you see the pattern of recurrence, I just put this picture. This is a weird diagram from that paper. Basically all the vaginal recurrences are the vaginal cuff. And the next most common second recurrence site is, it's like a distal third, that is less than 10% is the lower third, very urethral region. So the consensus is target volume should be limited to upper third of the vagina or maximum upper half of the vagina. No need to treat the entire vagina. Now suppose in this above case, there was no cervical involvement, but if there was a cervical stromal involvement, will you still go ahead with vaginal brachytherapy, or you will revisit your decision for external beam radiation therapy?
So it will become stage 2.
Stage 2.
Yes. Then we'll go to EBRT.
EBRT followed by both.
Because cervical stromal involvement is there. Yes, that is this. If you read in between the lines of PORTEC 2, VVT achieves excellent vaginal control as EBRT. But if you see, the pelvic recurrences were more frequent in the vaginal brachytherapy group. It is around 6.3%. So there are certain subset of adjuvant RT patients requires EBRT, and this is the ESMO, ESGO, ESTRO consensus. Means where there is more probability of lymphatic involvement, you have to go ahead with EBRT. Like cervical stromal involvement, inadequate nodal dissection, substantial LVSI, or poorly differentiated tumors. Now after this, will you consider VBT boost? You have given, instead of VBT, you have given external, like PORTEC 1 and PORTEC 2. You have given EBRT. Why you want to give vaginal brachytherapy? Will you consider it or not? Why?
So involvement is there.
Yes. So the consensus is
yes, we are going to give
vaginal brachytherapy boost. Again, there is no strict guideline for this, but the conventional teaching is when the lower third of the uterus or cervix is involved, like isthmus involvement, cervical involvement, vaginal involvement, or like positive margins, where there is high chance of local recurrence, you will always boost your pelvic artery with vaginal brachytherapy boost. And there is another reason, because some teachers have taught me like this. Like, see, vaginal vault, if you, especially in this era of precision radiotherapy, the movement of vaginal vault is not small. See, lateral centimeter 0.9, and it is around 1 to 2 centimeter movement can be there. So always there is an uncertainty is there, but again there is no evidence for this. So always they will say whenever you give RT, better you finish it with vaginal brachytherapy boost. But there is no evidence for telling, like, so any underdosage happens during the EBRT, you have to give vaginal brachytherapy boost.
Anyway, now we follow bladder protocols. I think most centers follow bladder protocols. This 2.9 is with bladder and without bladder, what you are showing in the picture. So I think with bladder protocol we can reduce it
with everyday imaging also.
Yes.
Cone beam CT imaging. This will be definitely come down. With the depth dose prescription.
5 mm from the circumference of the applicator.
5 mm or surface?
From the surface of the applicator.
Whether you prescribe your dose at the vaginal surface or 5 mm
beyond the surface.
Below the surface. Below the surface. So why this 5 mm came is basically because the vaginal thickness is 4 to 5 mm and you want to irradiate the entire lymphatics which spread across the vagina. And there are actually studies which have shown that the 95% of the lymphatic channels are located within 3 mm. So the that paper concludes like that, if you are giving only vaginal brachytherapy, yes, you can treat with 5 mm, but when you add VBT as a combination to EBT, this can increase the vaginal toxicities, so probably you can consider prescribing to the vaginal surface also when you add VBT as a boost. This I will skip for the sake. So we have discussed the uncertainties of EBRT because of the vault movement. What are the uncertainties in vaginal brachytherapy?
The sizes may not fit, size of the cylinder may not fit, and there may be gap between the cylinder surface and the
vaginal.
Sometimes the adhesion
will be there.
So that won't be uniform, the upper part excessively most part.
So basically we have found that the vaginal apex is the most crucial point we need to irradiate. The problem, but dosimetrically vaginal apex is the most uncertain point because of the distance of the apex, because first dwell position is not always at the surface, it is always at a distance from the tip of the cylinder. And the curvature of the apex is also important. And third, anisotropy of the source, especially with iridium compared to cobalt, because it throws direction not uniformly across all directions. So dosimetrically, apex is the most uncertain region. That is why always, if you see the recommendations, you say apical dose point should be more than 90%. That 10% is for the uncertainties. To add to these complexities, because of our surgeons' different styles, see, you will encounter all these shapes in your daily practice. Dog, Gothic arch, 2 dog ear, 1 dog ear, and like an Indian club, wide upper and narrow collar. You won't fit our things. So to add to dosimetric uncertainties, you will get all these sort of vagina. That is because of their various style of suture and the anatomy of the patient. So we have only this one vaginal cylinder, and you want to fit into all this one size fits all approach we are doing. So more than the EBRT, it is VBT will have more uncertainties than the EBRTs. And to add to this uncertainty, as Sundaresan sir correctly told, we have this air gap problem. So different shapes will be there, it won't exactly fit, so it will have air gaps. And when there is air gaps, there will be dose reductions. And as an icing on the cake, depending upon how they suture the vault thickness will also vary. So vault is the most uncertain areas. So when you give only vaginal brachytherapy, now you want to add instead of VBT boost, whether you want to add an EBRT boost because of this much things. So always this evidence-based experience versus evidence debate is never ending. And rather than viewing them as complementary to each other, I think case to case we need to take a decision. Like with VBT alone, whether we are able to give an adequate dose, because this 3D printed custom made is easy to tell, but to put it into practice is difficult. So whether to consider EBRT, or I just want to make this point, like just based on the evidence, you should not take a decision like I will go ahead with external radiation or vaginal brachytherapy. You should also put your mind into consideration whether I will be able to deliver proper dose with vaginal brachytherapy alone. So with that I will move to the molecular classification. The same case, 1B, grade 2, we did molecular studies. It came as pole positive. MMR negative, P53 negative. So it is pole positive. Now will you revisit your decision to give vaginal brachytherapy?
Yes, pole positive is usually low risk group. So we can keep it under observation.
Observation. So the consensus and our guidelines is pole positive, you can keep under observation. Yes, that is correct. But I just want to make a comment like, see, all this the survival comes from the retrospective analysis of PORTEC-3 trial. PORTEC-3 trial was you compared adjuvant RT versus adjuvant chemo RT. So irrespective whether they are polled positive or negative, all these patients have received RT, either RT or chemo RT, and the evidence is like even chemo RT it was 100%, only RT it was 97%. So none of these patients were kept observation. So based on this data, how far you can keep this patient under observation is the question. So whether we have to wait till PORTEC-4A trial has to come, Rainbow trial has to come, how far we can de-escalate at this point of time.
See, only for low risk after molecular classification we follow wait and watch.
The guidelines it is there, but how far the evidence support this?
I usually go with vaginal brachytherapy for this patient even if it is poll positive. So one
As per guidelines we can safely keep under observation, but we should keep this also in your mind. We don't have a strong evidence to keep them under observation. Now the next question is how to go about multiple classifiers. This you will be all telling. Multiple positives are there, how to go about them.
Molecular classification like pole mutation, we should do MMR and also P53 mutation or not. These are the latest molecular classification.
So if multiple positivity is there, first we will take into consideration of pole. Pole first comes in the hierarchy. If pole is positive, even if MMR or P53 is positive, that will not take into consideration. Only if pole is negative, you have to go to MMR. And if MMR is positive, even if P53 positive, it won't take into consideration. Both pole and MMR is negative, then only you can classify it as P53. So that is how this hierarchy comes. Now we will go to this thing. This is even not less than 50% of the myometrium is involved. 1A grade 2. No LVSI. And pole is negative, MMR is negative, P53 is positive.
I prefer to give external beam radiation instead of vaginal brachytherapy.
So it is 1A, not even 1B. 1A grade 2 pole positive. Pole P53 positive. High risk. External beam radiation therapy.
We should add chemotherapy with this. Concurrent chemotherapy.
Yes.
Because 53 is positive.
Yes, because high risk, you have to add chemo also.
Sorry for joining late.
No problem. Madam,
This
1A
is
grade 2 pole positive. Only RT or chemo RT?
Pole negative.
Hello, P53 positive.
P53 I would prefer to give chemo RT.
Chemo RT.
Maybe I would sequence like concurrent.
That I will come at the most.
Because this is a high risk, it's always better to give
chemo radiation. Yes. So unlike the other one, like I told about the pole, here we are escalating it. So it is RT versus chemo RT. So with RT compared to P53, compared to RT, chemo RT has got higher relapse-free survival rate, 59% versus 36%. So here we have more ground to hold. So always we can escalate it after shared decision.
I just have a small question here.
Yes.
In every other solid malignancy, P53 is taken as a factor.
Yes, sir.
Here alone, P53 comes last and pole is taken. Why is that so?
Because they are telling like when pole is positive, the mutational burden of the tumor is more. That has resulted in high tumor infiltrating lymphocytes. So because of that immune reactions, immune angle only, the tilt to the favor of body is taking care of the cancer things. That is why because the mutational burden is very high, tumor infiltrating lymphocytes is very high, so pole is considered to be like better prognosis.
Then why not go
take MMR into consideration rather than
Correct. I don't have answer.
direct comparison.
Yes. So how will you sequence this chemoradiation?
This patient, the nodes were negative, right?
Yes.
The only risk factor is P53 positive. So maybe I would prefer to give a concurrent chemo.
How will you sequence it? Like PORTEC3?
Yeah, exactly. Concurrent chemotherapy followed by adjuvant chemo. Yeah.
Same.
Chemotherapy followed by radiation.
Entire chemotherapy followed by radiation. 6 cycles carboplatin followed by radiation.
Yes.
Sir, coming to Balaji sir's question about MMR, now it has been shown that MMR cases are more amenable to immunotherapy. Immunotherapy based trials have not come out, we have not got adequate trials results. Maybe when they mature, we will be able to answer that question. Here I go with RT, concurrent RT followed by adjuvant.
I think 7 years back, when I was just starting and I was in PMH, so we had a sequence of initially giving chemotherapy, then followed by RT. It was adjuvant RT, not CPRT. That was the concept was they were not able to finish the chemotherapy because of radiation-induced myelosuppression. So they could not finish the 4 cycles of chemotherapy. So usually give it before. But now after JOVI and PORTEC, it has shown that better chemotherapy followed by chemotherapy.
Is there brachy inside this?
How to inculcate brachy into it if there are like positive margins, is there?
Because along with pelvic, after pelvic RT, you give 2 sittings of brachy and then proceed with carboplatin. That's what we do in our institute.
Not put in that.
Because that
is high risk positive margin. Straight.
Because even in PORTEC3, not all patients were given vaginal brachytherapy boost after EBRT. Only selected cases.
Early disease either EBRT or vaginal brachytherapy. High risk EBRT.
So since it is there, that's just to know how this schedule came. It was from an old study in 2004, RTOG 9708. This study is very important because this is the first study which integrated concurrent chemo with an adjuvant chemotherapy in endometrial cancer. Only difference was here instead of carboplatin it was cisplatin. It was cisplatin. Later it was changed to, in PORTEC3 it was changed to carboplatin in the adjuvant instead of cisplatin. And the rationale for that was the combination targets both local and systemic diseases. Cisplatin during RT aims to act as a radiation sensitizer because we are giving only low dose and it will not cause much toxicity, and the adjuvant will take care of the microscopic systemic disease. Now, this is another case, the last case from the molecular thing. This is again like here it is more than 50%, so it is 1B grade 2, and it is pole negative, MMR negative, P53 negative. So it is NSMP, intermediate risk. 1B intermediate risk, peritoneal voice cytology is positive.
Yes, stage 4.
Because molecular classification has simplified this confusion, because if it is pole, we can push more towards observation. If it is P53, that group will go for some adjuvant therapy. But here again we are back to square one. It is intermediate risk. Will you consider anything?
Peritoneal wash is positive.
Peritoneal wash is positive. So
it will be high risk. It will be chemo only. Management will be chemo only.
No, chemo
No
followed by
radiation.
radiation. No, for endometrial.
but peritoneal voice cytology is not taken into consideration for any staging or for the high risk. Note in the risk stratification, note in the staging. it is completely out. They have not taken into consideration. So previously it was a dilemma, but now that dilemma, in that some cases because of the pole positive we can push more towards observation. Because of P53 you can push towards adjuvant treatment. That is why I specifically selected this intermediate risk. Because we have data, this is actually I think the last AROI or before that AROI, this was a topic given to Vasan sir. We just pushed it into publication. Thanks to Krishna Kumar sir. Delving into the depth of peritoneal vash cytology, it was a systematic review. And because of the heterogeneity of the population and multiple studies, positive and negative studies, actually we don't have studies. These are the various options like observation, adjuvant chemotherapy, adjuvant hormonal therapy. Different people have done different things, but we don't have evidence to this. In institute, what we do is we give hormonal therapy instead of chemotherapy if it is ERPR positive. But some people have given adjuvant chemotherapy. But we can't say this is right, this is wrong, because we don't have evidence to this. And final, this is for our chemo schedule. This is the real high risk. Like 4 nodes are positive, so 3C1. Here how will you schedule chemo radiation? Still concurrent chemo radiation or like 6 cycles chemo followed by RT?
First chemotherapy, all the cycles of chemotherapy. I will complete all the cycles of chemotherapy.
Concurrent cycles. See, actually we have 2 trials for high risk endometrial cancer. One is PORTAC-3, which is concurrent chemo followed by 4 adjuvant, which significantly improved the failure-free survival rate. And then comes always this PORTAC and GOG will do some, there is no like PORTAC 1 for GOG, 2 high intermediate criteria we have. Like that here also, GOG again went and compared like chemo alone versus chemo RT. And it showed that RT is not required, chemotherapy only is required. And this arm, it's like 6 cycles chemo alone is required. So, but if you compare these two, if you see the PORTAC-3, it is more of early endometrial cancers, more rather than the high risk endometrial cancers. If you see the GOG, it is more of 3C1 and 3C2. So obviously by adding RT to 3C1 and 3C2 will have, when the majority of the population is 3C1, 3C2, 4A, it will not reach the statistical significance. Whereas in PORTAC-3, it was like more of the early cancers. So by adding RT along with chemotherapy will have much more role. So which schedule we need to take, how it guidelines changed after GOG 258 is, they have given first option as chemotherapy alone for all high risk cases and consider adding radiation in cases you feel like there is high risk of local recurrences. Now how will you add radiation to chemotherapy? You will have a sandwich schedule and a sequential approach. But evidence which is better is limited. Like other than PORTAC-3, these are the other schedules that people used to do. Like 3-carbopacly, RT followed by again 3 more cycles. Then this, when I was in Amrita, we were practicing this. 2-carbopacly, then RT with 2 cycles of cisplatin followed by 2 more cycles. And here in the institute, we follow like 6 cycles carbopacly followed by RT. So here, which is better? It's a choice. Is we don't have evidence. Institute to institute, the protocol varies. But this one is clear. When it is more towards early stage, high risk, we can always incorporate concurrent chemo radiation. But when it is more towards a high risk, high stage, advanced stage, you can always push more weight on the chemotherapy. And this I will skip for the sake of time. Inoperable CA endometrium, this I am skipping. This is definitely RT, I will skip. And thanks to my team. Thank you.
Thank you, Ram. It was a wonderful session. Though it was the last session, you made it so interactive with your presentation and your questions were so precise And though they answer, you intimidate them also with your further questions, and it was nice. Thank you.
Thank you.
To be up.
Sir, here. Sir. Usually we can do P53 and the MSc in IHC one only. Suppose
Yes.
In resource consent setting, you always need to do poll or IHC is enough if it is coming positive in IHC.
Because now poll comes first in the hierarchy.
Okay.
If poll is positive, even if your P53 or MMR is positive, it doesn't have a value. But another thing is, the polled population is only 5%.
Okay.
If you do 100% of the cases, poll become positive is 5 or less than 5%. So that is also a catch.
Okay.
But whenever possible, you have to do the poll because it comes first in the hierarchy. If it comes as positive, then P53 and MMR doesn't have a value. But I think I have seen some papers. I have not gone through it. I think it is in this last month Gynec-Oncology journal. They have something about the IHC marker for poll, but I have not gone into it, so I don't know about. I cannot what they have done. I cannot comment now. But people are trying to explore this aspect, how to bring a surrogate marker for poll in the IHC. But that is actively going on. Maybe in future it will come up.
You already said it's 5% chance only. But what do you recommend in resource constraint settings?
I will always recommend if poll is positive, you have to do poll. As of now.
First, we'll do IHC for all early stage endometrial, IHC P53 and MMR proteins. In that scenario, if it shows high risk, then we'll recommend poll is must. That thing we will do.
That's
in
what I was
resource
about to say.
constraint setting.
In early stage endometrial cancers, even the ESMO guidelines say, when the patient is already in the early stage with all other risk factors, poll doesn't alter the line of management. So we have to do P53, so it will upstage, then we'll alter the line of management. Only if the patient, if there is resource constraint, the patient is already in high risk, then poll will help you to downstage the patient.
Thank you.
Thank you, sir, to our moderator and esteemed panelists for your valuable insights and engaging discussion. We now invite Dr. Balasubramaniam, sir, to felicitate the moderator and panelists. We also invite Dr. Rajkumar, sir, to felicitate the chairperson. Ladies and gentlemen, with that we come to the conclusion of today's scientific session. Before we part, we announce the general body meeting.
Good evening all. Thanks for your patience till 6:30. Today's session we are concluding from this panel discussion. We are concluding the today's session. So next is general body meeting. Sir, all are requested to assemble here by tomorrow 7:30 sharp. It will start. separate sheet is available for, your people are requested to sign in the attendance sheet date 2. Then only your points will be credited for TNMC. So I request all to please sign tomorrow for the day 2 attendance. All please be sharp by 7:30 a.m. here. And also I added the complimentary breakfast will be till only 9 o'clock tomorrow. 7:30 to 9 o'clock. Morning 7:30 to 9 o'clock will be the breakfast and session will be from 7:30. மற்றவங்க எல்லாரும் போய் ரெஃப்ரெஷ் பண்ணிட்டு இப்போ 7 o'clock sir. 7:30 all are requested to come to gala dinner area by 7:30. All other members please wait for the general body meeting. Thank you. Non-members can leave, get your refreshments, be ready at the area by 7:30. Thank you.